Good morning, all. It is my pleasure to welcome you all to this important scientific webinar on Bridging Research Gaps in Tuberculosis, India's Path to Elimination, organized by the Indo-US TB program in the Department of Preventive and Social Medicine, JIPMER, under the leadership of the. I'm Dr. Shenbagwali, and I'm honored to be your Master of Ceremonies for today's session. This webinar is organized in commemoration to the World TB Day, 24th March 2025, with the theme underscoring the collective determination to eradicate TB by emphasizing three pivotal actions: commit, invest, and deliver. The number of attendees joining us today is a testament to our collective commitment to ending TB. Today's webinar brings together experts, policymakers, researchers, and frontline health workers to discuss progress, challenges, and the way forward in our collective mission to end TB. I encourage and request all of you to actively engage in the discussions, exchange insights, and explore solutions that can make a tangible impact. Thank you once again for your commitment and participation in this webinar. A few housekeeping guidelines to ensure smooth session. Please keep your microphone muted during the presentation. Please use the hand signs, or you can also use the chat box to get your chance during the Q&A session. Kindly be mindful that this session is being recorded. We will be sharing a feedback before the end of today. Kindly fill in the sheet for our betterment. The scientific sessions are being chaired by Dr. Sriram Selvaraj and Dr. Sanjay Sarin. We have a total of 10 speakers, 25 minutes talk followed by 5 minutes of QA. First 5 speakers will be moderated by Dr. Sriram Selvaraj, who will be introducing the speakers as well as moderating the sessions, followed by Dr. Sanjay Sarin. In the final 1 hour of the webinar, the chairs will convene concluding remarks. And we also welcome any additional comments from the audience during the concluding remarks session. To formally inaugurate today's webinar, I'm delighted to we are honored to have with us Dr. Sriram Selvaraj today as one of the chairs. He is a prominent researcher and scientist at the National Institute for Research in Tuberculosis, Chennai, an institute under the ICMR, Indian Council of Medical Research. His work primarily focuses on tuberculosis epidemiology, operational research, and clinical trials aimed at improving TB diagnostics, strategies, and public health interventions. Dr. Selvaraj has contributed extensively to studies assessing the effectiveness of control measures, evaluating treatment outcomes, and understanding the socio-economic determinants of TB in India. We are privileged to have our second chair, Dr. Sanjay Sarin, Chief Executive Officer, IKP Knowledge Park, who has extensive experience in global health with a focus on tuberculosis control, diagnostics, and health systems. Strengthening Dr. Sarin has played a key role in improving access to innovative diagnostics and healthcare technologies, particularly in low-resource settings. Before joining, he held leadership positions at FIND, Foundation for Innovative New Diagnostics, where he was instrumental in expanding diagnostic networks and integrating novel diagnostic tools into national TB programs. Welcoming you, sir, and I kindly hand over the sessions to you. Thank you. Over to Dr. Sriram Selvaraj.
Dr. Shenbagwali. Good morning and welcome everyone to this webinar today. So it would be an opportunity for us to retrospect ourselves. We have been doing a scale-up of diagnosis and treatment to a large extent, but still we are finding it a challenging situation to bend the incidence curve and to reduce mortality. So let us take this opportunity to see how we can find the priority research gaps and formulate future research strategies and evidences so that we would be able to bend the curve. And also, this would be an opportunity for us to prioritize things that could go in the national strategic plan, which currently NT is developing. So, without much delay, I would welcome the first speaker, Dr. Sonali Sarkar. Dr. Sonali Sarkar is a professor at the JIPMER with extensive experience in clinical, epidemiological, and public health research. Since 2010, she has been actively engaged in TB research and has played a pivotal role in several landmark studies. She was awarded the RONNH grant for the TB pregnancy and PREMPT projects and served as a key contributor to the JIPMER site in the Report India Phase 1, a multi-site Indo-US collaborative research consortium under the Indo-US Vaccine Action Program, funded by DBT and NIH. Over the years, she has completed 10 research projects funded by Indian and US agencies and currently oversees 7 ongoing projects under the Indo-US TB program, including a whole genome sequencing study funded by DBT. She serves as the Indian chair for Report India Phase 2 and leads AIM 1, focusing on validation of improved point-of-care diagnostic tools for TB. She will be talking on the current TB landscape, global and Indian context. Welcome, madam. Over to you.
Thank you, Dr. Selvaraj. Am I audible and are my slides visible?
Yes, madam.
Yes, Dr. Sonali.
Thank you. Thank you so much. Very good morning to all. We have a very great panel. Actually, it's my privilege to be part of this panel of speakers. And we have who's who of TB research in this workshop, in this webinar today. So thank you all for joining. I'll just give a brief to the today's webinar on the current TB landscape in the Indian context, especially focusing on the care scenario. So the burden of tuberculosis globally has been increasing. The incidence, here I'm focusing only on the incidence and the mortality due to TB. So as you can see here, the number of deaths due to TB were on an increase since COVID-19. So increasing from 10.1 in 2020 to up to 10.7 in 2022. But the 2023 report says that the increase has now slowed down and more or less stabilized. But fortunately, the number of deaths due to TB have been on a decline and consistently decline. The latest report saying it is about 1.2 million deaths in 2023. But the against the end TB goals that were set are still far below our targets. So the target of 50% reduction in the mortality, in the incidence of TB, we have reached only 8.3% globally. India report this released this World TB Day shows a 17.7% reduction in the incidence of TB in India, but globally it is still only 8.3% as against the 50% which should have been achieved by 2025. Number of deaths we have reduced up to 20. We are almost 1/3 of the way, but the percentages of households affected due to expenditure from TB is still very far off. You see here opposite direction, because here we want the proportion to come down to 0. We are still nearly 50% of the families globally are suffering from catastrophic expenditure due to TB. Coming to the Indian burden, the India TB report 2024 gives the incidence to be 1999 per lakh, but the says this is 195. But even then, we are far more than what we had expected to achieve the per lakh population of incident TB. The mortality is again still much higher than what we had targeted. It's still at 24 per lakh, 23 per lakh population. From India, we do not have the exact data of the families, the proportion of TB patients which face catastrophic expenditure, but we know this is quite high. TB is a disease of poverty and has profound social and economic consequences. TB distribution, the epidemiology of TB across India is very variable. As we saw from the reports in the National Prevalence Survey, it ranges from somewhere from 12 to about 595 cases per lakh population. And because this is a disease of poverty, we want to reduce, and our aim is to move from this, and this picture you see on the screen are patients of tuberculosis, cachectic, poor, suffering, to here you see a mother who's recovered from TB successfully, being happy and appears to be healthy. So TB actually is forms a vicious cycle with poverty. In the paper we presented clinical infectious diseases, we found that 67% of the TB patients had, and this is a study which is from combining data from all the centers, clinical research sites under Report India. So that is from 7 sites in India, and all over we see that 67% of TB patients had monthly income of less than 10,000, TB poverty being one of the major contributors and drivers of TB in India. But what we see is that poorer patients had higher risk of adverse treatment outcomes, and the risk was higher with the lower the income. So you can see the lowest income group had the highest risk of adverse treatment outcomes, which include death, relapse, recurrence, failure. So all these adverse treatment outcomes, in fact, make the families more vulnerable, because most of the time the TB patients are adult men and the earning members of the family. And when they die or they have recurrent tuberculosis, the family is further pushed into poverty, into catastrophic expenditure, and the risk of the family members to get TB again increases multifold. So this becomes a vicious cycle of poverty and tuberculosis. The National Prevalence Survey that was conducted from 2019 to 2021 showed there were highlighted the delays and difficulties in diagnosis of TB. One of the major factors that was brought out during this survey was the existence of a high proportion of subclinical TB in our country. So these people are asymptomatic mostly, or they do not fall into the typical symptoms that we characterize TB with, and therefore they do not seek treatment. But there is also a problem of not having highly sensitive screening and diagnostic tools for tuberculosis. Patients also face barriers to access health services, and delays in seeking care actually leads to 64% of the symptomatic population, those who have symptoms typical of TB, not seeking care. Many of them ignore symptoms. There's a very high proportion, 68%, despite having TB symptoms, were ignoring their symptoms, not recognizing the symptoms as that because of TB. Many of them went on for self-treatment, and some of them could not afford the care because many times they go in for private health system where they have to pay. So this led to a prevalence notification ratio of nearly 3, which means that out of 3 persons out there in the community who had, only 1 was getting notified, diagnosed and notified to our health system, and almost 2.8 not being notified, not being known to the health system, and thereby continuing to transmit the disease in the community. In a qualitative study that we conducted at a JIPMA site in Report India, we found that in addition to the previous factors that were identified in the prevalence survey, delays were also due to the lack of family assistance and inability to miss work, childcare responsibilities, especially in women, and delayed diagnosis because of misdiagnosis or confusion with another disease. But moreover, we also found the high level of enacted stigma. Stigma being one of the reasons why people do not want to accept their having are probably due to TB, and try for all other resort to all other modes of treatment and denying that they could be having TB. And unfortunately, the stigma was enacted stigma. They experienced this not only from family members, friends, relatives, people in the community, people, their colleagues, and other people at workplaces, but also in healthcare settings where the patients reported being, having been rude behavior, facing rude behavior from the doctor, not doctors, nurses and other health in the health facilities, and a lot of other instances were quoted. Continuing with the delays and difficulties, we see the delay in diagnosis is both due to patient side delay and also due to the health system side delay. And the health system side delay is almost nearly a month. That reports from low income countries say that this, even after the patient has sought care, has arrived at a health facility with symptoms of presumptive TB, but the delay in diagnosis has been nearly a month. The reasons for such delay in the health system is often because we have other forms of TB which are difficult to diagnose. The extra pulmonary TB, especially in the gut or meningitis and all, are very difficult to diagnose. Also, sputum smear negative pulmonary TB patients are often not easily diagnosed. But the reasons are also because of the tests that we have. We do not have, even till date, good point of care tests which can diagnose cases in the remote rural areas in India where the TB burden is the highest, the poorest, and remote tribal areas with very high TB burden. The burden continues because of lack of adequate tests. And the tests that we have, like Gene Expert and other molecular diagnostic tools such as TrueNat, are often unaffordable in such settings, and the maintenance on also system costs are high, and the international donations which will create a problem in accessing these in the countries where they are dependent on them. And other reason being that a lack of diagnostic test which can use alternative clinical samples such as urine, blood, saliva, buccal or tongue swabs, because a whole of the dependence on sputum is a difficult thing, because many times patients are not able to produce sputum or good quality sputum, which reduces the chances of their being diagnosed on time and appropriately. The other reasons of the delays and difficulties in the treatment the patients face are a lack of good host or mycobacterial biomarker. We even now have one size fits all treatment for all TB patients in our country. We are not able to personalize TB treatment, though we know that many of them do not respond adequately to this treatment. So we definitely need good biomarkers which would predict who among the latent TB infected people will develop TB and therefore treat them probably, and not all infected people. Diagnosis of EPTB, and also for prognosis and outcome of TB treatment. The potency of anti-TB drugs has also been questioned. We do not have many new drugs for TB in the pipeline. The few new drugs which came for DRTB, thankfully the betaquilin, delaminate, pretonomide, and linezolid. Some of them we are also started to seeing some resistance to these new drugs, unfortunately. So we do not have many new drugs in the pipeline still for TB as against other antibiotics. Dosage and the duration of treatment still remains a challenge. Long duration of treatment leads to poor adherence. And continuing with the other problems, we have delays in initiation of treatment. This is also a health system delay. The comorbidities that TB patients suffer from, like malnutrition, diabetes, HIV, substance abuse, all these complicate TB treatment. And in India, till date, we do not have a holistic approach for treating TB patients and their comorbidities. with all these conditions. And also the financial burden is still there, as we saw quite, I mean, nearly half of the TB patients are still being pushed, are teacher. So the difficulties in treatment also are the stigma, which we just discussed, is a major challenge that patients face, and this becomes a difficulty for them to access the health systems, where still some corners, some places, somewhere, some people uh, are not able to treat TB patients at equally with other disease conditions. Adherence remains a challenge because of the long duration of treatment. Nutritional support thankfully gained enough limelight and focus after the ration study was published in the Lancet journals. And now, recently, the rupees 500 that was being given as a direct benefit transfer to TB patients per month has been increased to 1,000. But even till date, we see that being given to the TB patients is actually not being utilized adequately for nutrition purposes, because these families are very, very poor. So the money that the government gives is rather spent on either school fees of the children or other expenditures at home, and not for nutrition for which it is meant for. There are other comorbidities, as we said, and diabetes, HIV, we have tried to and see the dual screening and treatment, but not all. Substance abuse and mental health is still a neglected patients, and which requires collaborations between departments, ministries, and holistic care. So I'll end with this, with the long-term consequences of TB being quite huge. We still actually do not care for TB patients much after the treatment is completed. Till recently, we were actually only worried that the patient completes the treatment, and we used to assume that once the treatment is completed or cured, the patient is healthy and happy. But it is not so. There are many, many long-term consequences. Realizing some of this are most of us know that the lungs has significant damage due to pulmonary TB, and the long-term consequences like COPD and other restrictive pulmonary diseases are very, very common in TB patients. Extrapulmonary TB patients have many other complications depending upon the site where they had the TB, be it GI, genitourinary, or brain. But central nervous system is again being recognized as being affected due to TB, and the impairments remain long after tuberculosis treatment is over. This is not just from TB meningitis, but other forms of TB are also known to have caused neuromotor disability impairments in children, which often go undiagnosed. Mental disorders, as we just saw, anxiety and depression are very, very common. The program says that they should be screened and they should be treated, but it's not happening till date. The TB syndemics, HIV, diabetes, smoking, undernutrition, are all these are added risk factors for the long-term consequences of TB. The program has now recommended a follow-up of 2 years from completion of treatment for patients of TB. But that is happening, but I'm not sure how far across all over the country, with nearly 1 million of TB patients in India, how many of them are actually being screened, so that the quality of life of these patients improves even after completion of treatment. So these are some of my references. Thank you very much. I'm happy to take any questions now or even later.
Thank you, Dr. Sonali, madam. So, if there are any questions,
So we have one question in the chat box. What, according to you, are the most promising post-response or bacterium markers in blood samples to diagnose TB? From Dr. Dhananjaya.
Thank you for that question. Actually, there are many of our basic scientists here in this group today. I think many of them will be able to answer we have been working on biomarkers. Many of them have been tested, lipidomics, proteomics, transcriptomics, mainly host-based, but none of them have come to a stage where it can be translated into a diagnostic tool yet, a predictive tool, sorry, yet. But I welcome answers from, there are many, many basic scientists in this webinar today, and they can answer this better than me.
Yeah, still it is under validation, so we have to wait for that. And so there are a few more questions on the TB infection consequences. You want to answer it?
Do I have to go through this? I'll be happy to. So, Dr. Atul Vashish says, besides active long-term consequences of latent TB also need to be exposed. Okay, yeah, latent TB, we know many of them will develop active TB. I mean, 5 to 15% will develop active TB in their lifetime. But even if they don't proceed on to active TB, are there other consequences? I don't think there are much studies which has followed long term people with infection alone and who have not progressed to active disease. What happens to them? So we have cohorts now, large cohorts with people who have been infected. We are trying to follow them up. Some of our studies, we have followed them for about 2 years now. Some of them who were infected actually did revert back to being TB negative. So they are able to clear infection. We don't know exactly what is happening because the tests that we have quantified on as of now, possibly the best test to diagnose TB infection, when they revert, is it actually a true reversion or what is happening? What is the immunological background behind people who revert? And if they do not revert, they continue infected, what happens to them? We don't have much knowledge in this area, Dr. Atul. As soon as we have, and please feel free to chime in those who have some added information or you think I'm not answering it appropriately. So any answer would be most welcome. Dr. Nishit says, what are the possible reasons other than malnutrition in patients with less than 10,000 monthly income for adverse treatment? These are multiple factors. Thank you, Nishit, for bringing this up. What we find is that patients who are poor, they don't only have more of malnutrition, they are probably the ones who are more with alcoholic use disorders, with tobacco use, and diabetes is also more. The social gradient of all these NCDs is now changing. The poorer socioeconomic strata have more of diseases which are related to lifestyle, such as diabetes and other NCDs. So all this together, an individual who gets disease is not just having one risk factor, it's always an interplay and multifactorial causation for adverse treatment outcome. And these are also the people who are probably not adhering to the treatment properly because of, we find that those with alcohol use disorders do not adhere to treatment properly, and alcohol use disorder patients with AUD is also more malnourished. So multiple factors play a role, Dr. Nishit. Shafia Mehraj says, how to diagnose?
I think in the interest of time, we can respond in the
Sure,
answers in the
chat.
Q&A session. So we would move to the. But I just want to add one point in the context of Indian TB scenario. Like as we go or progress over the years, we are seeing that the vulnerabilities prevalence is increasing. So that is the context with which we should be planning our strategies for TB control, because diabetes is increasing, so malnutrition is increasing. So all these vulnerabilities are increasing on one side, and we have to strengthen our strategies for elimination in that context of increasing burden. And also like the exposure to multiple factors, the occupation changing, the work style, working population, migration. So all these are the context in which the TB program is working. So to control or eliminate, we need to strategize what are the changing scenarios in the Indian context, and then plan our strategies and intervention accordingly to handle that change in the environment also. Thank you. So now we would move to the next speaker, Dr. Camelia Rodriguez. Dr. Camelia Rodriguez is a distinguished clinical microbiologist and infectious disease specialist, currently serving as the consultant microbiologist and chairperson of the Infection Control Committee at PD Hinduja National Hospital and Medical Research Center, Mumbai. She is widely recognized for her expertise in antimicrobial resistance, tuberculosis. Dr. Rodriguez has made significant contributions to advancing diagnostic techniques and treatment protocols for MDR TB and has played a key role in shaping national policies for TB management in India. Her work also extends to hospital infection control, where she has implemented best practices to strengthen infection prevention and antimicrobial stewardship. As a prolific researcher, she has contributed to numerous publications and serves on several national and international advisory boards and guidelines in the field of TB and antimicrobial resistance. Welcome, madam. Over to you.
Thank you, Dr. Sriram. I don't think I'm as nice as you said, but anyway. Okay, can you see my slides?
Yes, ma'am.
Okay, fine. I'm actually going to talk on a different platform. The Sonali really spoke basic. This is a little technical, and the topic is, can targeted NGS MDR and XDR TB diagnosis in India? So just to sort of put into perspective, we're still not there. This disease that has taken 1 billion lives in the last 200 years globally. Just 1 in 3 are bacteriologically confirmed, and sadly, just 1 in 3 of DRTB are put in treatment. Despite the unsustainable anachronism of TB diagnosis, we seem to have the best. We're going from low complex NAT to highly complex tests, but we're still failing. And this is a really nice slide from Morton, who I borrowed this slide from, which talks about the pipeline, which seems so healthy and so great. You have Ultra, TrueNat, Expert, apart from Expert, the CBNAT as we call it, LPA, Expert, XDR, targeted NGS. So what I've done is I've just sort of, in terms of complexity, made this little triangle, and you can see the low complexity tests such as CBNAT and TrueNat have their issues. They're unable to detect the exact SNP. They're unable to pick up INH monoresistance. They're not great for paucibacillary, and they're actually not even great for mutations outside the RRDR region. Of course, we have less of that, and they have an imperfect specificity for synonymous mutations. There is also Expert XDR, and we just showed that this had really good diagnostic accuracy, but only for INH and fluoroquinolones. What about what India uses? We use the LPA at IRLs, and all samples are subjected that pass are NAT positive come to us, where we reconfirm the rifampicin resistance and rule out INH monoresistance, as well as do an SL if rifampicin is resistant or INH is resistant, and do a DST for these drugs. But again, there are limitations of LPA, the imperfect sensitivity for paucibacillary disease. We don't do it for smear negative. The open assay leads to contamination. They have a low throughput, stringent QC. And to me, the most important is unable to detect SNPs responsible for INH, RIF, etc. Doesn't detect resistance to first-line drugs such as ethambutol, pyrazinamide, repurposed drugs such as linezolid, clofazimine, and new drugs such as bedaquiline, delamanid, and PTM. What about pyrosequencing? That's kind of a low next-gen sequencing, and we're really using it a lot today in our lab for CSF, because we find somehow this clear fluid really gives good results, better than Expert. And we give the results within 2 days, and we find it really works well for TB meningitis. But the targets for DR variants such as ethambutol, etc., bedaquiline are not on board. So these screening molecular changes have been game changers, and we've come this far. Do we really need NGS for our country? This was a study we did with Zari, where we just looked at our data from 2020, and we found that our MDR rates were almost 27%. But sadly, 68% of our MDR had fluoroquinolone resistance on board. So obviously we need to get more, because we could only sort of put our patients who were, in Mumbai, we could only put them on these 2 regimens that are the newer regimen. So the advantages and limitations of molecular techniques are defined by targeted and whole genome sequencing. I'm not going through this, because just to sort of split it further, and this sequencing was really made possible. GFTB was deciphered, and 4,000 genes, and you can see whole genome sequences the entire genome. But as of now, you still need culture isolates to perform it well. You can do it directly from sample, but there are gaps. Targeted NGS has the ability to directly perform on sputum and even detects mutations to the new and repurposed drugs. And the best part is it just takes 2 to 3 days. So this was a nice publication by Stefan and his group, which actually showed the concordance. All the time, clinicians keep asking us, okay, you're doing targeted NGS, you're doing whole genome. Tell us, how does it correlate with the so-called gold standard? And I keep telling them, sadly, the gold standard that is phenotypic DST is not that gold. The reasons are the inaccuracies of DST because of critical concentration issues, and sometimes poorly reproducible, especially for drugs like ethambutol, etc., which are actually not recommended by the WHO, but we still do them. NGS can detect mutations that mediate lower MICs below the critical concentration and are useful today. And you can see the discrepant are very few in this slide. And this is one of the best publications. I really like it because it is, I think this was by Stefan, or this was the TB Net group, which kind of actually tells you, it assesses high confidence mutation as predictors of phenotypic DST. That means if you get this mutation, no need to do phenotypic DST. It identifies mutations that need an increase in the drug to overcome resistance. And the best part is it assesses the effect of treatment outcomes when you rely on these mutations. So at the end of it, you will be able to say, okay, I have this high confidence mutation, great, or not so great, I can't give this drug. I have this mutation that can allow me to increase the drug, and I know how well my patient will respond when I rely on these mutations. Now we got lucky, the world got lucky with first line TB drugs, because really the resistance and look at the resistance to HRs, E and Z, all in the late 90s. Unfortunately, we haven't got that lucky with the drugs that we need today, that is linezolid, bedaquiline, clofazimine, pretominid, and delaminid. And what ails implementation of genomics in TB endemic countries like ours today? Of course, it's cost. Everybody says, oh, cost is not an issue. It is the issue. Technical expertise, capital building and expertise, and integrating NGS into existing diagnostic lab workflows is an issue we need to contend with. And how do you clinically interpret sequence data? I mean, my clinicians come to me with some reports from some outside lab with some vague mutation that I can't even find on the WHO catalog. And I say dump it. Because if it's not listed on the Indian catalog or the WHO catalog, just reporting some mutation really doesn't mean anything. And operational, of course, they're really not POC. Forget, they're not even POC. POC means plug and play. None of these are anywhere near that. But I believe complexity is really the enemy of implementation. And how you batch sample really depends on the flow cell capacity. And there's huge positive part. It's so comprehensive for resistance prediction. It will really help our program, especially for DR surveillance and outbreak cluster. So if you look at the WHO, the V3 is much awaited. It actually is, DST is challenging for the group A drugs. As you can see, the group A drugs are the ones that actually begin to define XDR. And I'm going to actually show you a case. This is a doctor. She is severely breathless, cough, emaciated, and with high grade fever. I show this case just to show you. She met with a really sad end because not because we couldn't help her, because she was fed up of treatment. And here you have, she was on treatment since 2019, diagnosed with MDR 2019. She was put on treatment, stopped all drugs with severe adverse effects, took bedaquiline alone for 9 months. And she came to us in November 2022. Her smear was positive. Resistance was detected, and our LPA showed that she did indeed have pre-XDR. She had bilateral disease, and surgery was considered. On the basis of what we had, we could just tell that she's pre-XDR, and we could look at these more than 1,000 nucleotides. We needed to wait for at least 4 to 6 weeks for DST to these various drugs. In this situation, what should we do till PDST is available? Should we just empirically put her on something because she's been exposed to so many drugs? That's when we decided that till whole genome sequencing can be optimized to perform well on clinical samples, targeted NGS is well poised to provide faster and comprehensive results directly from clinical samples. It takes 1 to 2 days, and the outcome is genotypic, and the DR and susceptibility prediction is well understood. So we actually use the duplex. It predicts resistance to 5 anti-TB drugs, even heteroresistance, and identifies more than 100 species. The good part of this is that in some cases, the ones that are with stars, the entire target is sequenced. That is with RRS, with RB0678, with RPSL, PNCA. This is important because there may be various mutations that we missed if we don't do the whole target, whole gene. I really believe INH and fluoroquinolones. We must provide the same diagnostic standard of care to all our TB patients, regardless of where they reside, whether they live in a small village in Uttar Pradesh, or they live in Mumbai, or they live in New York. So sometime in 2020, we looked at targeted NGS and we found that it did meet what we wanted. It gave good agreement with expert LPA and pyrosequencing. It could identify species and it was useful for mixed infections. To this really nice study that was sponsored by UNITAID and administered by FIND, where we looked at culture-free TNGS for diagnosing DRTB. It was a multi-center clinical study actually we did 3 end-to-end commercial workflows. We used GenoScreen and we used ONT. And you can see we can pick up 18 genes, 16 genes in ONT. TAT was 3 days versus 2 days, and we could pick up mixed population we couldn't pick up mixed population with GenoScreen. Okay? So the sensitivity and specificity of LPA, GenoScreen, and ONT, this just shows that they did pretty well. They really did well. They were in the 90s for most of the first-line drugs. And when you evaluated these, we could give reproducible results, more than 95% directly from sputum. Isn't that amazing? Especially for GenoScreen and more than 94% for ONT. There was sequence failures when our reads from the initial tests, such as expert, were low or very low. The sensitivity of GenoScreen was more than 95% for the first line, 83% for the lower, but I can live with that. And somehow for linezolid, it wasn't that great. And similarly with ONT. And this was the potential to generate data compared to whole genome and PDST, which were held as the reference standards. And these are as you can see, looking at LPA and targeted NGS in the form of GenoScreen or ONT, whole genome sequencing and phenotypic DST. Genes. You can see the GenoScreen is this purplish fellow, and it's in the 80s. It's not bad. It's not 90s, but I'm happy with that. On the basis of that, WHO decided that it would approve, in principle, this particular kit because it was well standardized for INH, rifampicin, pyrazinamide, ethambutol, bedaquiline, linezolid, clofazimine, amikacin, and streptomycin, but it didn't give the green signal to all the targets on ONT that didn't sort of approve for ethambutol, pyrazinamide, bedaquiline, and clofazimine. So WHO actually endorsed this test. And we wrote this review where we actually showed the various tests that are available. And targeted NGS is here for 2 to 3 days directly from sputum. So these are the targets, just to sort of show you. These are the various targets and the various genes that are available. Bedaquiline, linezolid on board. But there is always a but in life. That is, when we try to apply targeted NGS for smear negative EPTB, my problem in my hospital is maybe it's tertiary care. We get a lot of TB meningitis from various sites. And we looked at 20 culture proven CSFs. So we knew there was no other diagnosis, and we ran them against pyrosequencing, and we found that MTB unfortunately could only be detected in 7 out of 20. So it clearly needs to be optimized for smear negative. Again, this particular kit that we used didn't have an extended panel to delaminid and pretomanid, which is important because our country is getting into BPAL. And believe me, it has to have a simplified workflow. It is really complicated. You need really smart, skilled technologists to do this. What about ONT? I think this has a future, especially for India, because you perhaps don't have to invest in capital equipment so much. A laptop will do, and that's much cheaper. And though WHO hasn't approved certain targets, I think we're getting there with this particular test. And this is how the readouts come: easy to read. The ones that are in blue can't be used, etc. So this was a nice publication by Stefan, which sort of talked about the implementation of targeted next gen in low resource settings. And I urge all of you to read it because it's a good publication. It talks about, look at this Venn diagram here. Here's targeted NGS, here's PDST, and here's expert. Targeted NGS is overcoming all the drugs, whereas expert, even this is including the expert XDR, is only so many. And plus, you need to look at a whole lot of site identification, timeline, ethics, and cooperation contracts, budgeting, and human resources for target ranges. This is too long for me to go into the details, but he's given a flowchart where you can do it. And what about us in India? If we were to actually look at our diagnostic cascade for programmatic management, the ones that are sort of installed here, they tell us what we are blind to when we're using our usual algorithm. So we are blind to, if we use expert, if we use LPA, we are blind to ethonomide, ethambutol and pyrazinamide, and ethionamide if we are using here. For MDR short regime, we're blind to bedaquiline, pretomanate, clofazimine, etc. So there are some blind spots when we put our patients on this. And I just made this chart because I thought this would be nice for us in India. So how would we place it in our algorithm? TB patients go for a NAT, they would go for an LPA, and I think in terms to sort of save costs, all pre-XDR should be put through targeted NGS because it will tell us all about this. It will tell us drug resistance prediction for these drugs, for all the new and repurposed drugs, as well as the two first-line drugs. And what about cost? Look at the cost difference currently in a public sector, or it's our poor government who's bearing the cost. 2,000 for ultra, 3,000 for 2 LPA strips, expert XDR costs this, pyrosequencing costs 6,000, targeted NGS big time, and whole genome cheaper. This was a very nice cost-effective study that was done by the Canada group on detection of TB drug resistance in India, South Africa, and Georgia based on what we had done for the Lancet publication. And it actually showed that targeted NGS proved cost-effective in South Africa, but not in Georgia. In India, NGS dominated in-country DST practice and provided greater health impact at a lower cost. But when comparing targeted NGS with universal phenotypic DST, it really dominated by it was dominated by PDST in all 3 countries. And this is, I mean, to be honest, I'm a little dull, but I couldn't really get into all the ICER. But it seemed to be that the cost utility analysis based on the algorithms followed in each country from the perspective of healthcare system that was done actually showed it to be pretty effective. So why do we need this? One, as I said, upfront universal DST to most drugs and has the potential to revolutionize expansion for comprehensive DST. It interrogates the entire genes to identify specific targeted mutations associated with resistance. It may provide, it needs improved accuracy compared to the existing WRDs. Parties has an operational efficiency of 2 to 3 days, and it detects resistance to new and repurposed drugs that are not included currently in. So does it have the potential to become the future TB DST? Phenotypic DST, let's say, the standard of care takes culture positive 3 to 6 weeks plus 10 to 14 days for the DST. Whole genome sequencing needs culture positive plus 2 to 5 days. And targeted NGS is 2 to 3 days. So will it replace? Definitely, whole genome sequencing is going to be the ongoing surveillance. I think countries are going to, this is not targeted, this is sequencing. Whole genome sequencing is definitely going to be improved for surveillance at all global and national levels because you have to continuously reassess this. Targeted NGS will probably, if we have the money, replace positive MDR with a TAT of 2 to 3 days. Not really. I don't know what's going to happen for possibacillary samples because there's still knowledge gaps on new resistant confounding variants. So where research input would be useful, where I really feel we need urgent resolution is relatively low rates of resistance of new and repurposed drugs. Because it's so low, we think, oh, it's okay, we don't need to worry about it. But I think it really precludes urgent deployment. So we have a handle on how resistance is increasing. We need to understand the nuances of genotype-phenotype discordance, especially for the new drugs. Most important, we need to either develop in India, do something to reduce costs with validated, quality assured kits. This is the magic word here. And secondly, we need the cost of flow cells. See, the flow cells come in various sizes. You can do nano, you can do mini, and you can go from 4 to 48. Now, I can't tell my pre-XDR TB patient, you know what, wait till I get a batch. The test has to be done in 2 to 3 days. And I think that must be the prerogative when you promise to get into these technologies. Again, we need to optimize DNA extraction methods for possibacillary TB, for HIV, for pediatric TB, and especially in serious infections such as TBM. Like I told you, we had 17 of 20 in PSQ versus 7 out of 20 in targeted agents. Thank you.
Thank you, madam, for enlightening us on how we are planning to move towards TNGS. So if there are any questions that you...
Can we ask?
Yeah, go ahead.
Yeah, Dr. Camilla, it's always, it's so pleasant to listen to you, and with all sorts of information that you pack in a limited period of time. It's very, it's really amazing to listen. So my question is on this country-specific MTB whole genome sequencing efforts. Do you think that will give us a identify novel SNPs, and those things can be integrated into the NGS test?
Absolutely. Dr. Ranjan, India, the DBT is now doing 32,000 whole genome sequencing and correlating that with DST. And where you get a discordance, those isolates are going to be looked at very carefully to see if they're solo mutations only in resistance or only in susceptible. We have to see whether our mutations are the same as the ones described in literature, or we have some novel mutations, and those will define. We are already moving in the right direction, I think, because this is whole country. We are taking isolates from most zones of our country. So I think we will be much better placed to say that these particular mutations have not yet been described by WHO. We will need to validate it, certainly. And once we have that, we can put that on a targeted mutation platform and do it.
Yeah. Thank you. Thank you so much.
There's one question in the chat box by Dr. Sonali Sarkar. So, how frequent are the mutations and how soon should we modify the panel in case of targeted NGS?
Sonali, I think that's a great question. But see, currently we're doing nothing. We're just relying on DST. And to be honest, to get the wretched powder, I'm sweating and running to customs daily. So it becomes a huge issue even to do phenotypic DST. Forget about doing specific targeted mutations for the new and repurposed drugs. But having said that, I think there is a future to look at the new mutations once we correlate them with well done phenotypic DST. Does that answer your question, or was I off course?
Yes, maybe answer. Thank you.
Yeah.
Question.
Thank you, madam.
Atul. Sorry, sir.
So I think the important point which madam tried was to make this technologies available to people at large and at scale. We need local technologies to be made so that it could be scaled and cost could be reduced. So that's an important thing that we need to take it forward. Thank you, madam.
Thank you.
So we'll move to the next speaker. Next, we will be having a talk on tech-driven innovations for TB diagnosis and surveillance.
Dr. Noel here.
Dr. Shibu Vijayan. So Dr. Shibu Vijayan is the Chief Medical Officer, Global Health in QA. He is a public health expert with over 25 years of experience in medicine, epidemiology, and health system strengthening. He serves as a Chief Medical Officer for Global Health at QA, a leading company that leverages artificial intelligence to enhance healthcare access and quality. His expertise spans project design, implementation, monitoring and evaluation, proposal development, and business growth. He has worked extensively on public health initiatives in India, Ethiopia, and globally, collaborating with organizations including WHO, PATH, Medicine Sans Frontiers. As a former global TB technical director at PATH, he led pioneering initiatives in tuberculosis care, including the Public-Private Interface Agency and AI-augmented innovations for TB management. He has also contributed to global policy documents and best practices in the field. Welcome, sir, and over to you.
Just give me a moment. I'm just sharing the screen.
Sure.
Thanks for the introduction.
Thank you.
Can you see the screen now?
No, sir, we are not able to see.
Okay. Password. Is it visible now?
Yeah, it is visible, sir. You can put it on a projected.
Okay, thank you.
Yeah, now it is full screen. Please go ahead, sir.
Okay, thank you. Good morning, everyone. So thanks for the opportunity. So I'm just going to present the tech-driven innovations in TB and diagnosis and surveillance. So as you see that in the slide that there is a leaking care cascade of from the population level risk as well as from the incident cases. Each step there is a critical leakages. All these steps are actually relevant when it comes to the technology applications. Starting from estimating the population level prevalence, and then whom to be targeted for screening, and then whom to be targeted. Whom are getting tested, how many lows is happening there, how can we plug in that gap, and then whom we are kind of putting on treatment, and then following up till the disease-free interval. So that's how it is being structured. So the presentation also goes from the theme of actually preventing, screening, testing, diagnosing, and for treatment and follow-up. So you all know that what you are seeing in your friend is actually the Nixia, which is a repository of case-based real-time notification system. I just want to give you the acquaintance that India is one among the pioneer countries who have kind of digitalized this thing, and that opens up a lot of immense opportunity to apply other tools, including artificial intelligence and technology. So, in the absence of a real-time notification or data aggregation systems for any diseases, that will be a major limiting factor for applying any innovation, technology-driven innovation. So this is the at least I would say the need digital intervention. So as you all know that a TB patient pathway is starting from the community. Then somebody has to present to the health system with some symptoms, and then you get screened. Then there'll be testing happening, and then treatment initiation follow-up till the end of the treatment. And then now, as globally the TB program envisions, we also need a long-term follow-up. So that's how it is structured. So each of this step have relevance of applying innovation. So as you look, I mean, as I mentioned earlier, so what I try to, this is again from a Government of India document, just wanted to mention that this has been prepared in consultation with many partners, technical partners, got insights from WHO, country partners, and also global technology experts as well. So just this is potential scope for it as when the document was prepared. But what critical changes happened, that is very recent changes in the advancements in artificial intelligence, which kind of actually have a disruptive approach when you think about how the application of technology comes into play. As I mentioned, so prevention, identify the risk areas and population for latent TB infection testing. Automated skin test is available now. Treatment adherence for latent TB infection. Treatment adherence as such has been kind of digitized, and there are which is now getting much more smarter with AI applications over it. On the detection, chest X-ray is much more, I mean, and much more prevalent, and also I would say from a legacy standpoint, the application of technology per se, both from the hardware innovations and also the software innovation happen in that area a lot in the recent years. Especially, you might have seen the tiny X-rays going around household and screening for TB cases. And also the artificial intelligence tools are available for interpreting X-rays and flagging probability. Cuff is another area which is getting traction. I'll go into details of it in the subsequent slide. Then again, on the detect side, we also have an interpretation tool for line probe assay interpretation. Again, that's an image. That tools are being deployed in the program setting in India. On the treatment, we know that treatment requires a little bit of counseling and to identify who has the potential to kind of stick on the treatment or who has the potential to lost to follow-ups. There are prediction tools available, which has been developed by country partners who are now being deployed. There are tools, there are adherence toolboxes, there are treatment adherence support, cool systems like 99 dots or smart boxes, pill boxes available. On the other side, the build side is something which is the technology has not a lot, but again, there are potential scope is there, which I'll mention from a futuristic perspective, how we can utilize our entire Nixia repository of informations for generating reports, smart tools. So moving on the prevent. So as you see that this is actually a plot, risk plotting, the prevalence plotting from the estimated numbers overlaid by the notification number. So this is auto-generated thing. So what is the use of all these things? And you also know that now this is actually TB numbers. You can even overlay this also opportunities to overlay multiple other data points like a socioeconomic data, socio-demographic data, occupational information. If there is a mining community there, we'll get it further. So not only notification information, but again, other parameters. For example, air quality index is a key risk factors for predisposing lung ailments. So these kind of heat maps will help in targeting. So now country is actually targeting 100-day TB campaign. So the TB campaign, where do we do it? Where do we do it in the high risk population or in the low risk population? That is where I also mentioned about the next part of it. Again, it also need to be augmented by other parameters like the social data. So this is a representation. This EPCON is a partner who works on this thing, and we do have a small patchy implementation in India in pilot level. But again, some countries are actually utilizing this in large scale as well. You might have also heard about the TST test, which is now being implemented in the program, which is a CY TB test, which is a Indian manufactured Mando text for that matter. The skin test is administered in the forearm as class way of doing it. How it is getting interpreted is now it is manually. The plan is to have some sort of measurements which can be captured in a camera and automatically say there is a probability of high risk, and then the patient need to be put on treatment. So currently it has been the induration after injection is being measured by technical staff or even interpreted by doctors to kind of initiate on latent TB infection treatment. What is envisioned is that how we can automate this part of it, right? Even the automation of injections. So there are self-injectable, like something similar to our insulin pen, right? Can we load this thing on an insulin pen and then put it over there, and then the reading could be automated by taking a picture in a mobile, and that about how whom to be put on treatment. So you enable the decision making further down to take that decision, maybe at the health worker level or at the health and wellness center level, or a CHO can decide on whom to be put on treatment. As I mentioned, the cuff space is now getting crowded because cuff has a signal has some sort of fingerprint nature to underlying lung diseases. So there has been many experiments done with multiple precautions. Some are cuff counting, some are cuff characterization. So what is important when it comes to probability of TB flagging is more characterization than the counting. Counting also would have value. Let's say if I'm having cuffing, my cuffing frequency has been on treatment probably coming down. That's a good sign of maybe my resolutions. As I depicted here, there is a lot of companies which are in different levels of validation available. Again, the use case is flagging a potential probability from your cuff sound at risk probability, and then escalating to for further testing. So again, so none of these tools are actually deployed from a TB standpoint in program setting, but they are in the research and evidence generation, except Hive, which is largely used for cuff counting. So it has two different applications. It is actually personal, individual patient level application, and also a population level application. Imagine in a population, if a decent proportion of the people have this Hive device to and information to be captured, okay, we can also longitudinally track the characteristic of cough happening. Not the characteristic, the count of cough happening. Let's say 100 per 100,000 is the cough prevalence in this week, and that which has been changing to 200 per 100,000 the next week, which has a significant implication, maybe a pandemic in cooking or not. Similarly, if my cuff frequency is been increasing, if I'm on some medication for lung diseases, that also is a good indicator for my personal intervention. Coming back, so we just the X-ray is, as I mentioned, X-ray is one of the key parameter for screening and identifying and assisting this detecting this decisions. So as you see, X-ray AI also got a lot of traction, and I'm representing this company here. Essentially, all the X-ray AI tools will help in automated interpretation of just X-rays, and and also flagging couple of it all have multiple type kind of findings. As doctors see in X-ray, could be the computer could be trained, and computer also give an automated output of it. But the use case for here is tuberculosis. So what exactly the AI does is that it calls out whether it's subnormal or normal. Also give a probability score based on it, and many partners are working on it. Many technologies are validated. The only thing, when you are actually would want to use this thing in the programmatic setting, make sure this have decent validations, enough evidence generated, and approved in country. So because as this market is also getting crowded, lot of unvalidated tools are also in practice. So just be cautious when you ask the right questions and get all the certifications thing. So typical use case of X-ray based AI-driven case finding is, as you know, active case finding. There is not enough expertise available in active case finding setting, because most of these are actually remote settings. So you use tiny X-rays to take the X-rays, and then someone has to interpret it. Interpretation is now being automated by AI. The not very typical of the use for X-ray and AI in the normal setting. So the second thing, which I'll also detail a little bit on the next slide, is an incidental case finding. Let's imagine this AI is going to screen all the X-rays happening in a health facility, because typically in a district hospital setting in India, around 150 to 200 X-rays happen, just X-rays happen per day. I'm not saying all these X-rays are happening for TB. So for multiple reasons, doctors will order for maybe pre-anesthetic check, maybe after a trauma to check whether this, the thoracic wall is intact or not. Wellness checkup, multiple. So regardless of the reason for X-rays being taken, the AI will get an opportunity to scan it. So this is exactly what Mumbai Corporation has tested it, and that's wonderful findings. So it's a so if you can imagine in India, 100 million X-rays are happening per year. So 30 million of that in public health setting itself. Let's assume that 30 million, I mean, usually what we see that around 20% of them are potentially probable TB cases flagged by AI. And 10% of them are typically we see positivity in Indian settings. I mean, just it varies from region to region, but again, on an average, it's 10%. So there's huge potential to leverage an existing infrastructure and use AI to pick up incidental TB cases. Similarly, in Vietnam, they tried among the TB patients looking for lung nodules and then screen further profile for lung cancer. And they also did find a significant case. I mean, lung cancer, potential lung cancer cases. So what I'm trying to say is that these tools are not only restricted to tuberculosis, it has a potential to move towards lung health, which is a direction I think even WHO is also going. You might have also noticed that very recently they published the integrated lung health guidelines. Because the disease-driven approaches is not the way forward. Probably we need to look health system standpoint. So I just wanted to mention that this is how the incidental pathway is being designed. So as I mentioned, all the patients who have been undergoing X-rays will get an opportunity to scan through AI, which is installed in the X-ray modality. The picture what you see here, even analog X-rays could be digitized with the mobile application. So there are technological advancements to convert the analog X-rays, and then you apply AI. So it's just a click of in a mobile camera, the things can get solved to a large extent. So the advantage of incidental case finding in facilities is that most of these facilities are co-located with molecular testing, either TrueNat or GeneXpert or other tools available. So your leakage chances of patient getting lost after being identified as a presumptive are relatively low. So, as I mentioned, there are tools available now to interpret LPA. This is also as simple as like looking at the images and trained. So the Wadhwani AI has actually prepared this thing. They've trained millions of data sets, computer with millions of data sets of LPA, and now being deployed in a pilot level in few places. So the use case of this is again, we are actually improving the quality time for the high resource, I mean, high skilled people like those who are microbiologists or lab technicians who have high skill in interpreting LPA. Will get so that most of these tools have they will identify normal with a high level of precision, so they can focus on the abnormal one a lot and then agree. So it's a quality time will be available and then faster turnaround, and that's the efficiency, the operational efficiency is the key part. So as I mentioned, that when we talk about adherence, lost. So how do you profile patients? So there is a lost to follow-up tool which has been now AI driven, being developed by National TB program, which helps in identifying the adherence risk, and also the patient with the highest score could be prioritized for actual DOT, and those who are having less score probably will need a soft touch adherence reminders. As you all know that there have been adherences, advancements in adherence tool like 99 dots, which is essentially when you are plugging. So your tablets are put on a sleeve. When you plug out the tablets, there is a number or a which we give a call to that number that will be identified as a tick in your in your adherence plan. So it's a remote adherence support system. Similarly, there is a medication event remind monitor, remind monitor box, it's MERM box. which again, as you see in the picture, there is the medicines are segregated in the box. Most of these are actually now utilized in the TB domain, wherein there is a signal, there is an alarm, we can time the alarm, so it beeps out, and then when we open the box, that signal will be captured automatically as a pill in the hand information. So these two technologies are more or less pill in the hand information, which is a surrogate indicator of patient would have taken drugs. So what adds value to the national TB program is the health worker who are chasing down, or the community health who are actually chasing down the patients for direct observed therapy could have a priority level based on the lost to follow-up profiling, and they can they can target their support for adherence to people who are in need than everyone. So you might have seen the personalized chatbots. TB Arogya Sati app is getting some traction in actually looking for what kind of services available. Government of India is also thinking in making it much more smarter with newer advancements in AI, making it much more conversational stuff. So the point of care ultrasound is another tool which is now getting a lot of attraction, especially in the so ultrasound has broadly had value in gestational age, but point of care ultrasound usage being explored because there is devices are available, tiny devices are available, which is portable, which we know the output could be in a mobile. So this point of care ultrasound could have value in both pediatric as well as an adult TB from a triage perspective. So there are conversations already on with the manufacturers and technology partners and ultrasound companies to actually look for exploring lung ultrasound as a triaging tool. This also have applications for pediatric TB, especially extrapulmonary lymph node tuberculosis. Look at cervical lymph node or axillary lymph node. Deeper lymph node, which will be tough, but again, still, this is one more tool available. This will probably in another couple of years that we would anticipate this also will be in the market as one more additional thing. There are quite a few things in the pipeline, genome-based diagnostic tools, which I was just listening to Dr. Camilla's talk. There are AI applications. One of the Indian partners is Arogya AI, which will ease out the interpretation of the. So one of the key things from the genome sequencing is the interpretation of that is going to be require high skill set. So that could be automated. So your report generation time will be could be less. So point of care ultrasound I did mention. So there is as I mentioned about adherence tool, which are giving surrogate signals. There are actual signals. We can see patient taking videos. So do we need to monitor all the video, or like can we kind of look at only at problematic videos? So there are AI tools available to say that patient hand movement to the mouth could be recognized, and then say these are patients who are not done the pill properly, or something like that could be. Network optimization of diagnostics. Again, AI tools could be utilized by functioning, so whether capturing the functionality of the diagnostic tools available. Let's say a network of GeneXpert or TrueNet is not functioning. How many of them are functioning? How many tests have been done? There's a huge opportunity in exploring that. A clinical decision support system for care providers using LLMs, because there are. How can we capture? While we are capturing some of the, let's say I'm in a slum, then if the patient is malnourished, if the patient is smoker. So based on the risk profile itself, the patient could be referred for testing, or could be sample could be collected. So much more smarter tools are now in the pipeline to make decision at the point of care. Staff training requirements could be automated. Many of things are now automated. We have small WhatsApp videos and demonstration videos available. Data entry free chatbot. So that's something which is many countries are now testing. Again, it's not available in the market for the deployment. Conversation between a patient or a community health worker could be captured as data points and also be generated. There are next steps could be prompted from the chatbot to the health worker so that they can actually act fast. So the data entry is one of the key challenges. So that also could be solved in the recent time. I mean future. So as I mentioned, there's Nixia is a wealth of information. How can we kind of decipher information from that to make sense out of it, right? So generative AI driven national strategic plan. So like let's look at the information. So how much notification you had, what kind of profile of notification it is coming, and can we add on other data sets and create reports out of it? So that's slightly futuristic, but again, that is possible probably in our next strategic plan, which is not in the pipeline, but again, the subsequent strategic plan will have some smart inputs from Nixia generated by generative AI. Rest of it is all treatment monitoring, clinical radiological progression, recurrence prediction thing. Okay, who is going to recur from profiling, and also who is from the latent TB infection? How can we predict who is going to develop active TB? Prediction of ADR. These are all possibilities by capturing information using simplified chatbots. So before I stop, I just want to kind of like all of you to reimagine a little bit, because we might have already seen this how we kind of this picture from Reimagining TB Care website. But essentially, what it says that let's assume that if I'm going to an outpatient department with coughing, somebody will profile me with the cough AI and say, "Oh, you have probable TB," and then you go and take an X-ray with an AI interpretation. Probably a smart stethoscope, the doctor will say, "Oh, fine, you have some lung damage, which is have functional thing also." Probably there will be, I mean, when my sputum, I'm put on treatment, when my sputum is negative, somebody will offer me a handheld spirometry with an AI interpretation, say your lung damage, you have some residual lung damage, steroids or bronchodilators. Then I put on treatment, I'm monitored by smart pill boxes, and I'm complete my treatment. So that's something which is probably, it is possible as of now, because we have tools available in most of this, the patient pathway. It's a matter of actually how soon we can decide and then move on. Thank you so much.
Uh, uh, nice elaboration of the technologies that are currently there and that are expected to come. So, can we take one or two questions?
Yeah.
So there is one question. How can AI help add site TB results to Nextshare so we can track patients, follow them up, and predict who might get active TB? Are there studies available on this?
There are studies, I mean, in the pipeline, not available as of now. But that's a good question. That's why I mentioned even there are studies even looking at even simple cause response biomarkers like ESR or even CRPs, some association with that, with the, I mean, other along with some radiological and also some biomarkers. So that once that study is over, associated with, I mean, as Kior, we are associated with UCT study on a long-term follow-up of such cases, both LTBI as well as subclinical tuberculosis. That will also throw some light on whom to be followed up, even if CITB is positive, whether what is the potential of breakdown. So which requires a lot more research before doing something. I mean, I'm hopeful that soon something will come.
Thank you, Dr. Shibu. One more question from Dr. Atul. Can AI ML tools help in predicting LTBI, DR LTBI, and its long-term consequences in household contexts of active TB patients?
If the question is, I mean, if possible, yes, possible, but depends upon what data variables and what science is available. As of now, that is evolving. When that data variables are available, then we can overlay that into existing information, and that will give much more better prediction. Again, eventually, none of the AI tools are not in a completely independent. It's all adding efficiency to and skills to the clinicians or health workers. So just be cautious about having it. I mean, when we are thinking about can AI independently decide? No. But AI can actually throw more insights and help us in deciding much more efficiently.
Thank you, Dr. Shibu. Is there any tool
Yeah,
available
Yeah, please.
assisting patients, for example, advices, counseling, etc., from Dr. Nishit?
So TB Arogya Sati was actually conceived to do that, but it needs improvement. So it actually currently helps in connecting with the call centers and connecting with the National TB program remotely. But it could be made much more smarter and much more efficient. Again, yes, that is the vision of a National TB program, to make it much more smarter. It is possible. It has some elements right now, but again, not fully as envisioned. Thank you.
Thank you. Thank you, Dr. Shibu. Before we move, hand sign from Dr. Vivek Rao. Please go ahead.
Shibu, hi, Vivek here from IGIB. Uh, Good to see you. I'm actually traveling now, but still, I just want to ask a question, whether it's so you have now TB coming up in areas where there's a lot of comorbidities, like for example, TB silicosis with lots of viral infections, respiratory infections, COVID and TB. How good is the AI in delineating different diseases and the changes in the lung uh, morphology or in the lung physiology that we can detect and assign exactly, saying that it's a TB cough versus say TB plus COVID cough or a TB silicosis cough or just some other infection, respiratory infection.
Yeah, it's a good question. So there is some, how do we
Hello.
differentiate a mixed infection and then probably say this is more TB, more silicosis. Globally, there is a push for silicosis and pneumoconiosis because that's again go hand in hand with tuberculosis. So there are algorithms for silicosis, silicotuberculosis, and tuberculosis separately. COVID, yes, there are specific findings. So as I said, because there is a specific finding which also give a TB score and also calls out, because AI tools also calls out, rule out if it is a mixed infection of silicotuberculosis. Say there's a probability of tuberculosis, let's say 0.7, and probability of silicosis is 0.6. So once you rule out one diseases, there is an opportunity, or there's another pathway to be covered, which is actually a silicosis pathway to be ruled out. So all these are having huge triage value and decision making value, and none of these things is in a diagnostic tool as of now. It is recommended because it requires a lot more validation before making it automated. I don't think that we are in that domain, especially when it comes to infectious diseases. The ground truth is almost always a microbiological diagnosis or a clinician, post-clinician
Yeah.
lab. So just
Yeah.
cautious. But again, it's possible to have the decision-making process much more easier. So we are also working in that direction. We have silicosis algorithm and also a COVID algorithm, and also progression monitoring. The other part is that the AI can quantify, let's say, 70% of the lung involvement, and then subsequent sequential X-rays have that coming down is an indicator of like the better treatment response. That is also possible in the current scheme. Thank you.
Okay. Okay.
Thank you,
Thank you.
Dr. Shibu. So we will take questions later. And I see Dr. Jayatyagi as one of the participants. Thank you so much, ma'am, for joining. I also see Dr. Sethi, Dr. Uma Devi, Dr. Harvinder, Dr. Kannan. Thanks for joining, and please stay with us until the concluding remarks session. Thank you, everyone. Over to Dr. Sriram.
Yeah. To add to Dr. Shibu's point, so it is important where we position the tools. That is more important, and as the tools become more validated, so it will give more confidence on using that. So that is important to consider. Whatever new tools are emerging, so we need to see where we position that, whether it is a triage tool or a diagnostic tool, and having an understanding on that would have more relevance and more confidence in implementation. Yeah. Now, thank you, Dr. Shibu. We will move to the next talk. The next talk would be on socioeconomic barriers for patients with tuberculosis and engaging communities to ending TB by Dr. Ramya Ananthakrishnan. Dr. Ramya Ananthakrishnan is the Executive Director of REACH, a civil society organization working in the field of TB control for the last 18 years in Chennai, South India. She is a medical doctor with a postgraduate degree in community medicine. She has been working for the last 14 years in the field of tuberculosis. She has contributed to much in shaping the policies in private sector engagement for TB care, in TB champions, capacity building, gender and TB, and she has served on many advisory boards and committees for TB and community engagement. Welcome, Dr. Ramya. Over to you.
Thank you, Dr. Sriram, for that introduction. Can you please confirm whether you are able to see my screen?
Yeah, we can see your screen. You can put it on projected mode.
So at the outset, I'd like to thank the organizers for giving me the opportunity to talk about the socioeconomic factors and commitment in TB care. And I think since morning, we've had some very rich talks on various aspects of diagnosis and clinical care. And I think I'm going to be taking you to another spectrum of the whole care cascade, which is looking at the impact of TB on the family and the person with TB. And also today, a lot of traction on community engagement. How do we get affected communities to also be part of such conversations, on scientific conversations, and how we can partner with them? Because ultimately, at the end of the day, whatever research happens, whatever technology we find is for a person with TB and person with symptoms of TB. So talking very differently from previous speakers. So I think all of us agree that TB is a social disease. And I think that is one of the major reasons why we continue to still grapple with the problem of TB, despite having a diagnostic test and a treatment available both in the public sector and in the private sector. And I mean, I think the previous speakers had mentioned about the various diagnostic tools, technology, but I think unless we are able to think on what the social barriers which a person with symptom of TB faces, I think that whatever technology we have will not reach those who need it the most. So I think all of you, as I mentioned earlier, very well know that the structural determinants of the health, that those are factors which reinforce social stratification in a society. And this can lead to inequity and factors like living conditions, psychosocial circumstances, behavioral and biological risk factors. They all contribute to a person's health-seeking behavior. You may know that the recent prevalence survey, which was conducted by ICMR, I mean, Dr. Sriram is here, so that 40% of those who turned out to be sputum positive actually did not have symptoms. So then it throws a $1 million question, right? So how do we get people screened? And even symptoms of TB, if you take it is very common symptoms like cough, fever. So how do we associate a person with these symptoms and get them motivated to get themselves tested? And how do we also overcome the huge problem when we talk about the socioeconomic factors, a stigma that prevents people from testing themselves? Because I think if you are more than 30, or no, if we are obese, we immediately get tested for diabetes, or if we are in a job which doesn't require much physical activity. But if we have cough or if we have fever, we never get ourselves tested for TB. So how do we break that shackle? I think those are the important factors that we need to consider while we look at delivering a TB care both sector sector. Now, as I mentioned, the social determinants are among the key risk factors for TB. For example, poor ventilation and overcrowding, workplace settings like quarries and glass blowing, and of course, mining. So these increase the likelihood of unaffected people being exposed to TB infection. And of course, conditions like poverty, malnutrition increases susceptibility by a disease. So we all know that TB and malnutrition is a vicious cycle, and one leads to the other. And in fact, good nutrition is one of the very effective vaccine for TB. And but I think here we have a huge problem of malnutrition, undernutrition, with sometimes BMI even less than 14. So I think these are some of the socioeconomic factors that we need to look at when we think about bringing the technologies to the doorstep of a person with symptoms of TB. So in terms of when you look at from the exposure, the entire care cascade. So this was one of the graph which was from the social determinants of tuberculosis from evident to action. So from exposure to accessing TB care and clinical outcome, as you can see, at every step, there are multiple factors which play an important role in determining whether a person with symptom of TB is able to seek care or not. So these are either intrinsic factors, it could be biological factors, it could be factors related to the marginalization. So, and being the gender-based factors. So, how do we take into consideration all these factors? And I think it's very important to understand each and every variable in these different settings, so that we are able to reach the people with the right diagnosis and motivate them to also complete treatment. So moving on to the economic impact, I think one of the main goal of TB program is to have zero expenditure. But then when you look at the cost for TB care, we still see that there is so much of expenditure happening, out-of-pocket expenditure happening in a person with TB, and this includes direct cost, indirect cost, cost related to medical expenditure, loss of wages for the day, and the quality of life, decreasing earning ability. So each of these, again, factors play a huge role in determining whether a person is able to adhere to treatment, whether the person is able to seek care at the right time. And it's important to examine all these different factors because in public sector, we have diagnosis free of cost, we have treatment free of cost. We also have the direct benefit transfer, where the government of India is providing rupees 1,000 per month for a person with TB. But beyond this, we still have a lot of out-of-pocket expenditure, especially in the private sector. Now, in our experience, we also see that this out-of-pocket expenditure is substantially higher if a person is diagnosed with extrapulmonary TB as compared to pulmonary TB, because in a public health viewpoint, pulmonary TB has a maximum attention and maximum focus, whereas extrapulmonary TB actually faces a little bit of a challenge, because the diagnosis of extrapulmonary TB itself is pretty challenging, and it requires diagnostic tests, which has a cost to it, and also recovery challenge. When we break down the cost, so we could look at this from a public sector viewpoint, from a private sector viewpoint, from the type of TB, whether it's pulmonary TB, whether it's extrapulmonary TB. And of course, currently we also have the huge challenge of drug-resistant TB, where again, the cost implications are substantially higher. And also, when you look at the quality of life itself for a person with DRTB as compared to drug-sensitive TB, we find that it becomes very difficult for a DRTB person to go to work despite getting, even though they may be on the path of recovery in terms of getting back their energy. And even after taking full course of medication, in our experience, we find that many of them are not able to go back to their original job, and they need even post significant challenge in terms of overall morbidity. So again, as I mentioned, stigma, of course, is a huge problem, and it continues to still be a problem, which I think all of you know the definition of stigma, and I think this is where again communities' participations and communities' involvement in research becomes very, very why there is stigma. Of course, there is a fear of transmission because it's an airborne disease. We saw that in COVID, and it's been there in TB for ages. And also the association. So there is a lot of myths that it's linked to poverty. It's only a disease of poverty. It's only a disease which occurs in people who have lifestyle issues. And again, it also causes a lot of social concerns like shame, guilt, loss of reputation. And some of this is a perceived stigma. Some of them are actual stigma. Again, when you look at stigma itself, there are many, many dimensions. You have the enacted stigma, which is the direct discrimination. You have the anticipated stigma, where there is no stigma, but there is a fear of discrimination. There is a self-stigma where because of all the negative connotations associated with TB, there is a lot of self-blame. And we see that especially very high in parents of children a TB. And of course, secondary stigma, which is a discrimination affecting TB, a person with TB, their family members, and the caregivers. And again, because of the stigma, it has various rights, right, from impact on the career. So there is a care. There are a lot of social issues, and again, it has a big impact on mental health. So when we talk about stigma, of course, today, currently, we have many efforts going on. In fact, we were part of the national stigma strategy that was developed, looking at how we could reduce stigma at every step in the care cascade by addressing barriers, by getting people who are actually affected with TB, train them as TB champions, by empowering communities, and by dispelling the myths and facts about TB, and also measuring stigma. So we had used the Stop TB partnership had come out with a stigma assessment tool, which we have been using to measure which looks at stigma at 4 levels. One at the level of a person with TB, second at the level of a family member, third stigma in the community, and fourth at the health system level. So just moving on to another very important because when we talk about research and especially research agenda for TB program, I think what is very critical and one area which I feel we should strengthen, especially the research community, how do we engage the communities for TB? So today we have, again, through various initiatives, successfully piloted and scaled up a TB survivor to TB champions engagement, where people who've been cured of TB were identified and trained and empowered to become TB champions. And these TB champions are contributing back to the TB program by providing psychosocial support to another person with TB. And they are also playing an important role in finding local solutions for people in their own community. So, for example, if there is no weighing machine in their DMC or in a tuberculosis unit, so they are able to mobilize local resources to get weighing machine, because TB treatment is fully a weight-based TB treatment. Similarly, if there is a microscope not working or an X-ray machine, there's no lab technician. So while the health system is also addressing these issues, the TB champions are playing a critical role in mobilizing local resources to help address these challenges. So these TB champions provide peer support. They make an outreach to improve the awareness about TB and to encourage and motivate other people. They've also been part of this whole community monitoring, because I think as a very important mechanism when we look at TB program and when we look at TB services being implemented, feedback is very important. I mean, we all know, even when we use apps like Zomato or Swiggy or your Olas and Ubers, there is a feedback mechanism. So this is very critical, which is healthcare delivery. So it's very important that we get feedback, and who better than these TB champions who do the community-based monitoring and provide feedback about the quality of care and quality of services. They also play an important role in treatment literacy and educating people with TB. They undertake various anti-stigma campaigns, effective case finding, and other efforts. So as I mentioned, in fact, that the TB program has released a guidance document on community engagement under the National TB Elimination Program. So they are needed in every step in the TB care cascade. And I think my urge and my request to especially the research community is, I think we need to engage with the affected communities, right? And their needs. So right from getting feedback, assessment, to getting them involved as part of community advisory boards when we have these research protocols, and getting their inputs into research protocols, to finally involving them in community-based monitoring. So every step of the care cascade, we need them. And I think if we were to truly achieve this partnership between the research, the clinical and the affected communities, along with the public, can definitely end TB in a successful manner. So again, I just want to leave with this, with, of course, thanking all of you for your patient hearing, but also requesting that we engage the affected communities, because they know best. So they have been the people who've gone through the experience. They know the challenges, and I think we need to listen to them while we design studies and research protocols. Thank you very much, and over to Dr. Sriram.
Thank you, Dr. Ramya, for this nice talk. If there are any questions, we can take one or two questions. So if anybody has any questions, you can put it on the chat. Thank you, Dr. Ramya. Now we'll move to the next talk. The next talk would be on TB genomics. So we have Dr. Devashish Mohanty, Director, National Institute of Immunology, who would be talking on TB genomics. Sir is an Indian computational biologist, bioinformatician, and is known for his studies on structure and function, prediction of proteins, genome analysis, and computer simulation of biomolecular systems. And his expertise would be very useful in understanding the host and pathogen interactions that would help us in transforming diagnosis and treatment. So we welcome you, sir. Over to you.
Thank you. So, just 1 minute, let me share my slide. So, are you able to see the full screen?
Yes, sir. We are able to see, sir.
Okay, thank you. I would yeah. So what I will just tell you about this is like it was under TB genomics, and I believe TB genomics and use of genomics all of you know well. So what I would try to concentrate is in this recently there has been a lot of application of machine learning with genomics, and there is a belief that probably it will help both in TB diagnosis and also in understanding mechanistic details of drug resistance, and then if we can think it can help us identifying new drug targets. So my talk would concentrate on that. It's the machine learning based approach for identification of resistance associated mutations in MTB, and that is the one. So this is something what all of you know. This is that the challenge is obviously, the phenotypic DST is the most reliable way of identifying the which drug it is resistant to. But typically, it can take about 2 months or even 1.5 to 2 months, and this one. But now, with the since the NGS has been cheaper and there is a quickly we can get the whole genome or a targeted NGS. So there are drug resistance is linked to distinct mutations which are present on the genome. So using that, maybe within a week, one would be able to predict drug resistance, what is called genotypic DST. And then, of course, that would help in the quick diagnosis of drug resistance TB and deciding the treatment regimen according to this. And in this area, there is a use of machine learning. And so my talk is going to discuss this aspect. So now, so what I am, this, yeah. So what I am going to cover is, okay, so you do have a drug resistance TB and you do it in a clinical setup, you identify the sputum sample or things like that. So now, and if we want to do, you could either take it and culture it and then get the send it for sequencing. But now, if you have cultured the bacteria and if it has some interesting mutations, some research group might like to work on it. So maybe it would be a good idea to deposit in a strain repository. And then once you got the genome sequence, you could do analyze and all the whole genome. And of course, you can use machine learning and all these to identify resistance associated mutations. We'll tell different methods of finding resistance associated. And so this is an effort which has started in India under India in TGS. This is Indian genome tuberculosis genome surveillance consortium or something. But what I would talk is not about in TGS. It will be talked in a different forum. It is in general about TB genomics and prediction of drug resistance and how to understand it for deciphering the mechanistic details of drug resistance. And just to give you this all of you know that is not tell you all that. So now if you cultured the bacteria and you could get enough DNA, and now if you can send it for sequencing, you may send it to a sequencing center, you could give it to a private companies who are doing sequencing. So once you get the raw data, these tools, which were once considered, oh, you should have a high-end bioinformatics lab or something, these days, these have been more democratized. In any setup, if you do have a average level server or a very high-end PC with a decent RAM, you will be able to run all these tools. They're all available in public domain. So you could use like things like Bowtie for read mapping, SAM tools for BAM or SAM files, and for variant calling, consensus generation, lineage identification, and AMR prediction. So, of course, this you may directly do, or you take the help of somebody else. This always important to understand what is the principle behind it. If you, of course, do it directly, you will know the steps. But sometimes you will use this data, so it is important that you understand it. So now, one of the things when you're doing all this sequencing, variant calling, and all, you should ensure that your sequence quality is good. That, like said, that you have got enough number of reads, and if you are using a reference genome approach, the number of mapped reads are significant. The majority of the reads are mapping onto the reference genome. What is your mean coverage and what is your average quality and all. So these are the parameters. All these tools will help you to ensure that you have got a good quality genome, and the variants which you are identifying, there is a reasonable confidence that these are actually present. It is not something you say it is a new variant, but the number of reads which are aligning with them is very less. So that means there could be a sequencing artifact or something. Once you take care of this, then you come to the, once you have which are the mutations which are present, based on that, you have to tell, is it a resistance associated this thing? Because as I told you, in this case, you are not going to do the phenotypic DST. So from the genome, you have to tell to the clinician or whoever has given you for sequencing that this is a resistance DB. If so, it is resistance to which antibiotic. So that is where, because every mutation, everybody will genome maybe S37RB, but every mutation is not linked to resistance. Even in the samples which are susceptible, there are a whole number of mutations take place. So you have to have some way of distinguishing the resistance mutation from the susceptible mutation. So this can be done by, there are softwares like TB Profiler which does it. They primarily do based on WHO catalog. It is a rule-based method. I'll tell you what is there. And in this area, we all also recently, there are many groups who are developing machine learning based tools. And I will tell you what are that about this. And there is some groups which our group has also developed that, but this is not the only one. There are many this. So I will tell you the difference between these tools and what are the advantages and disadvantages. And as I showed you, if you say like like you must have heard, WHO has recently released the tuberculosis mutation catalog of the drug resistance like tuberculosis. And this is the second edition which came some, and this is a very well curated catalog. So it has gone through almost about 45 to 50,000 TB genomes, for which you have a matched phenotypic DST profile. That means every genome they are using to build this catalog, for that particular isolate, somebody has done phenotypes come from many different countries, and you know that it is resistance to which antibiotic. So that is the data set on which you can really look at and say, okay, how this mutation is linked to resistant or something. So this is something that is a manual effort. So obviously, this is most reliable, but that is something which is likely to take time. That is why you don't get it every 6 months or every 3 months or something like a mutation, this one. And so these types of things, and for this, the whole result is given as a huge Excel sheet with all the mutations and all. Unless you are a real expert, it is not easy to go and detect it, this thing. So there are tools like TB Profiler. So what they have done is they have made a rule-based methods which are mostly based on WHO mutation profile or that sort of analysis. So those implemented. So you can upload your reads or your FASTA profiler and get it. So that is another way of methods. But what is happening is the drug resistance is constantly changing. So as new, this will only detect those samples in those where the mutations are listed in the WHO catalog. But as you know, there might be new mutations which is coming somewhere else. So how can we automatically detect it? And that is where the machine learning methods have the advantage, provided you rightly data and you have used a robust machine learning based methods, and that is what I will try to cover in my talk. So coming to that, this is essentially the WHO, as I said, WHO uses a manual criteria. So now it has to be present in any variant or a mutation which is linked to a resistance or susceptible has to be present at least in 5 isolates. And then they check how many times this mutation is presenting in susceptible samples, how many times it is present in resistant sample. Based on that, they calculate a odds ratio PV, and based on that, some mutations which are occurring more often in the resistant sample can be confidently ranked as associated with resistance. And some mutations which are more often occurring in susceptible samples, they may be occurring in few number of resistant sample, but based on statistics, they will be ranked as not associated with resistance. And there will be other criteria associated with resistance, interim, not associated with resistant, interim. But this is a robust method manual, and if you get a new resistance mutation, it will not cover it. It will be covered only when the next version of this comes. And those of you who are, and what they do is, where do they look for mutation? They look for these mutations, search for this mutation in a fixed number of genes, which are called tier 1 and tier 2 gene. So these are the gene like isoniazid, INH. They will look for CATG and INHA, FABG1 and APHC. But there are additional genes on which isoniazid mutations are also occurring. So using these mutations, they will be able to, using the statistics, they will tell you what is the associated or not associated, this one. And for those of you who are experts or working in the field, of course, you will know. But if you want a quick sample where you want to know which are the samples from which country, if you go to TB Profilers website, you can click, there is a link there, you will reach this. So what they are saying is, they have this many sensitive sample and this many resistant sample, and you can browse sample country wise based on their data. You can search for variants. With the variants means you search, you found a new mutation, some sequencing you did in your clinic. Now you want to know, and it is somehow not in the WHO list. You want to check, is it present in the resistant, this one? So in those cases, you might be able to search it there. So this is something, see, let us say a very well-known mutation like which is serine 3152 threonine in CATG is linked to, confidently linked to resistant. So that you are finding it is present in zero susceptible sample and most of the present in the resistant sample. So unlike that, I put a mutation which is arginine 463 to leucine. As you see, it is present in almost 46,000 sensitive sample, but again, almost 23,000 or 14,000, there are large number of resistant sample. So these are the cases you will not be able to confidently link to resistant, because it is occurring with a very high number of susceptible sample. This mutation will be ranked as not associated with resistance. So that is the mechanism. But this website is a good place where you can search for these mutations, what are the status, how many times, or things like that. But once you did this, now if you have a isolate, and what you did is you did this one, and you did a prediction. Now what you are doing is, based on the prediction, you are able to assign resistance. Like this particular isolate, let us say it has some number, just an identifier, don't bother about what it is. So a genotypic resistance prediction method, by just using the genome and computationally predict, it is saying it is resistance to isoniazid and it is resistance to ethambutol, like ethionamide. So now to all other sample, it is saying it is susceptible. And same way, the next sample is this. But now, if you have somebody has done the phenotypic DST, now what you are trying to do is, you will be able to compare these differences. Like what you are trying to say is, if you see here, as you can see, that all other, this column, what is saying is the resistance based on phenotypic DST. And as you see, and this column is based on genome based prediction, and they are matching. This resistant, and it is also telling you based on which mutation this genome software has predicted it as a resistance to ethionamide and isoniazid. So, but this sort of a prediction will always, it holds good in a large number of sample, and that is why we are confident by doing a genotypic DST, we will be able to predict drug resistance quickly. And it is only the challenge is how fast you can get a sequencing done in a clinic, and that is the major bottleneck. But the thing is, but at the same time, all these prediction tools have to be constantly validated, and we should think of how to incorporate the criteria for bringing new mutations onto it. So with this, I would just what the data as of now says is all these types of analysis, you would be saying that, okay, these are the different antibiotics, these are the different genes to which the mutations have been mapped. So now, and these are the locations of this gene. If you start from some position like gyre location and go to the end of the genome, these are the genes where the drug resistance mutations are mapping. They are located in all these places. So now, in case if you want to do a whole genome sequencing in the clinic, like all the thing, because you have to isolate culture and take the DNA, send for sequencing. Currently, it may take 3 to 4 weeks, which is not a good scene, because that's the time of a phenotypic DST. But instead of that, if you could do targeted NGS, you are in a position to do it quickly. A targeted NGS can be done if you decide the primers accordingly, target these genes and amplify those regions and send the DNA for live sequencing. You will be able to quickly get a large number of mutations in the time frame of 1 week, and that is why WHO is recommending that we could use targeted NGS in the clinic. Of course, that is what has to be validated and certified and things like that. So, but each of these, there is one more point here, like all the WHO mutation table is based on global data. So our Indian data may not be adequately represented there. Out of these 50,000, maybe I would guess that Indian data will be 4,000 or something. So if we have a new resistance profile here, it will not accurately reflect in the WHO criteria. And that is why it is important that we do our own sequencing. We develop our methods for prediction of resistance and map it. And that is what is required. So with that in mind, I would just try to, that is the basis of my talk. In the interest of my time, what I will do is I will try to skip some of the slides and try to tell you. So these are the, other than predicting the genotypic for a diagnostic purpose, how if you found some new mutations, it could be any of the antibiotics, you can get some idea about which pathway this antibiotic was working and how this new mutation is leading to resistance. So this sort of a mechanistic understanding can help you to design some newer drugs or things like that for that is the another use of this type of data. So this is what is telling you the whatever WHO list I had shown you. So with different drugs, which are the different genes where the mutation is occurring, and these red color genes are indeed. And I will just show you few examples to show how this mutation data you get from genome, which can help you to understand the mechanistic basis of drug resistance. So let us say these are few mutations with few antibiotics. Let us skip this slide. So now the isoniazid is a compound, is actually its target is a protein or enzyme called CATG. So CATG is converting this isoniazid, is a prodrug. It is acid acyl radical is a CATG, and that is going to be NAD adduct is forming, and that is binding to INHA, and that is how this molecule, the drug is blocking the mycolic acid synthesis. So now, in case you find a mutation in CATG, what is going to happen is there could be a mutation in CATG 315 to threonine, then isoniazid doesn't work. Or there could be a frame shift mutation, like somewhere the guanine, the G changes to a gap, then there is a frame shift, then the whole protein changes, and the new protein, mutant protein, is becoming 615 amino acid, and wild type was 740 amino acid. That means a portion of the protein gets deleted or the sequence becomes very different. So these are the type of things can have very drastic phenotypic consequences in terms of the pathway and the binding of isoniazid to CATG. And this is what we can understand if we map these mutations to the 3D structure. So if you see here, like what is going to happen here is, this is the place, this mesh shaped thing. This is the structure of the CAT-G protein. There is a heme bound here, and this is where the isoniazid was binding. Now serine was there, and it was optimal for this pocket, and now it becomes threonine. So this threonine is bigger in size. There is one more methyl group. So this molecule, the isoniazid, doesn't get enough space to bind there. And that is why isoniazid cannot bind. And that is what this picture is showing. And this is the way you mechanistically understand how this serine to threonine mutation in 315 is affecting drug resistance. But you may not always find mutations which are near the binding pocket, like tryptophan to 191 to glycine is a mutation which is very away from the catalytic pocket. So this case, probably a mutation at a distant site can make it more flexible, and allosterically it can affect binding. So that is how the different mutations can affect. I'll just go you like example this. If you have this frame shift mutation, what is going to happen is this yellow portion of the isoniazid protein, which was making contact with the heme group and isoniazid binding site, is just getting deleted. If this entire protein portion gets deleted, obviously this protein will not be able to optimally bind to this. So these are the way you can understand how drug resistance mutations you can map to drug resistance. It is not only the mutations in the coding regions, the mutations regions can also be linked to drug resistance. Like take an example of let us say a molecule of like a kanamycin, which is this one. So it was here the mutation is not on the target of kanamycin. It is mutation is at a upstream region which is regulating the expression of another gene, which is aminoglycoside acyl transferase. So now what this aminoglycoside acetyl transferase is doing, it to like acetamycin. So now, because of this mutation, if there is a overexpression of aminoglycoside acetyl transferase, so what is going to happen is this will quickly convert active kanamycin to inactive kanamycin, and that is how the drug resistance will emerge. Or same way, in other cases like pyrangenamide, there could be similar mechanism. So it is not always the mutation will be in the drug target. Mutation could also be in the non-coding or the regulatory regions. So if you search literature, you find many examples where partly linked to the drug target, the mutation there is affecting drug resistance, and this way you can understand. And if you take it other way around, these are the somebody else did the experiment, showed it and all. So if we are doing our own genome sequencing in the Indian patients, if we find a new mutation and we interact with people who have understanding of structural biology, understanding of biochemistry, we would be able to identify new mutation and understand, and this is why they are leading to drug resistance. So that is the purpose of my talk. So now I would all these things we talked of, like in the next few minutes, I'll say how machine learning is being used. So what machine learning is using is, you have a lot of data. Only if you have data, you will be able to do machine learning. So you have a lot of data. So the data was initially the scattered. Like if you just look at the raw to distinguish between intron or exon or a resistance versus susceptible. By machine learning, you are introducing some transformations because of which your data becomes easily separable. And these transformations are there are various types of machine learnings are doing this type of transformation. And what is important for that is, you don't need to go different methods. I'll skip these things for the purpose of talk. Like whether it is a intron exon prediction or a drug resistance prediction, you will be able to do machine learning to predict this. And in these types of cases, we can do, there are different types of machine learning, supervised and unsupervised. But the drug resistance scenario, when you have this 40,000 or 50,000 genomes, MTB genomes, where phenotypically their DST is no phenotypic DST is known, you can use that data for what is called a supervised learning. So that means for every data point, you have a label as resistance or susceptible. And now if you use that, if you could use this data from any database. I have just example of BVBRC, which was that is one of the data set, like a bacterial and viral bioinformatics center. It is in Virginia University. You could take WHO table, you could take cryptic data. So what you are doing is, when you go to your genome, you are mapping these mutations, and these mutations now, if you put it, you have a genome. These mutations, you can just encode this set of mutations are 1010. If there is no mutation, it will be 0. If there is a mutation at a particular site, it will be 1. And this is where is indicated as the filled box or empty box. And these samples are resistant and susceptible. So if somebody gives you a data set of 40, 50 genome, and you put that in a table or a matrix like this, we can manually look into it and tell, oh, yes, if this mutation is there, of this mutation, none of the susceptible samples have the mutation. That means it is a marker of resistance. But if the data set is large, we need to do some sort of a computational techniques, and that is machine learning is telling us to do. So what I would try to tell you is, like in this work, let us say, like we want to develop a machine learning model. For that, we take resistance sample, we take susceptible like a sample. But if I am developing a machine learning method, one way is I develop my method, then I do some prediction. Then after that, somebody else does the experiment to validate it. So then, of course, I can know whether my prediction is right or wrong. But that way, somebody will not be ready to do that many number of experiments to validate your method. So one of the way a computational biologist who develop the method is, they divide the data into a training set and the test set. So you have a portion of the data which you have used, and you have not that is the left panel on my this one. You have a portion of the data which you did not use in the training. So you will test your model on that. And now from the genome, you get this 1010 mutation profile for resistance and susceptible. And you can use many different types of machine learning, gradient boosting, artificial neural network, deep learning. You could even use language models. And then, and if you can predict antibody resistance for all the first line, second line drug, it will depend on how many examples you have in your data set. For isoniazid, you may have a lot of examples. For something like cycloserine, you may not have enough examples. So this is, but one more thing you need to check. Once you did this prediction, you have to tell whether your prediction is right or wrong. So like any diagnostics or something, you have to calculate the numbers. If it is between distinguishing between a green color or the pink colored apple, and somebody is predicting, you can color them. You can say how many true positive, how many false positive, how many true negative, how many false negative. So from that, you can calculate your sensitivity and specificity. So what sensitivity is saying is, you should do the true positive samples you maximize, and specificity is telling you is you are minimizing the false positive. The ideal goal would be to you should have high specificity. That means a minimum number of false positive, and high sensitivity is giving you the all the true, as many true positive samples you are going to detect it. So now if you divide all the antibiotics, you divided the data into training set and test set, and you did a prediction model. So this is some machine learning model. So we took about 30,000 drug resistance genomes. On that, we tested, made a training set, and remaining that we test set. So what it is telling you is this is the sensitivity and specificity we will get. And we are comparing it with TB profiler, like, which is a rule-based method, which is not like machine learning is sort of an automated method. You have only given them the genomes and the labels, resistant and susceptible. You have not told it like which rule to use. Whereas TB profiler has given you the WHO mutation table or some other rule. So as you see, in many cases, your machine learning is automatically derive these mutations and predict the sensitivity and specificity in a comparable basis. And I would skip this, but there is one more task here. So what we want to, ideal goal is, how can we do the new mutations? How can we identify? So this is done using what is called the interpretable AI. So in the interest of time, I will not go much into it. I'll just say there are thing called SAP score. So what you contribute is, we said because of mutation, this is resistant. So we want in our machine learning is contributing maximally to the classification. It is almost like a principal component analysis, you can say, but it's a little more complicated version of that. So by this, from all your mutations which you had lambda 0, 1 and the matrix I showed, your machine learning is telling these are the mutations which are strongly correlated to resistance, and these are the mutations which are strongly correlated to susceptibility. So you have not told this method about WHO mutation table. You have given just the genome and machine learning has identified. So isoniazid will have few mutations in the mutation table, but this machine learning has identified almost 28 mutations. So this is the way this method can give you new mutations which probably would not be there on the WHO mutation table. And this is something is a comparison here of whatever we predicted based on machine learning. As you see, most of the known mutations which are red, this star is being predicted. Of course, few known mutations are not predicted. There was no sample in our training data which contained that mutation, but there are new mutations have been also predicted. So I'll skip some of these slides. So all these mutations are now available as a like a TBMR PRED, which is a machine learning based method. So what you can do is you could either upload a read file here, or you could upload a FASTA sequence of the whole genome. So it is by using machine learning, it is able to tell which whether it is resistant and susceptible, and it is telling you which genes it has identified mutation. And if those genes which are in the WHO mutation table mutation, it is telling you as a bold color. But in addition to that, it has suggested you new mutations which could be linked to drug resistance. So with this, I would tell you some example. Let us say you take the streptomycin. This is an example where we found several new mutations. Like if you you may find a new mutation in a completely new gene, or in a known gene, you can find a mutation which is not there in the WHO list, that we call known gene new mutation, or it could be a known gene known mutation which is same as the WHO table mutation. And this is a case where many new genes and mutations were identified in GIT-B and all this. So the consequence of that is, if you see here, there were almost 55 isolates which were experimentally known to be resistant to streptomycin. But if you see that, if you see this one, if you take a TB profiler or a rule-based method, because those mutations are not in the WHO table, you are not able to predict them as resistant. But this method, which I XGB is correspond to TBAMR PRED, because we have located these new mutations. This method is able to predict all these samples are resistant. There is another tool, GenTB. They also used some sort of a machine learning method. They also predict some of those mutations, but not all of the mutations. So the point here, it is not to say that this tool is better than TB profiler or anything. Like you could get another data where our tool may not predict, TB profiler may predict better. But the point I want to make is, instead of going by a rule-based method where WHO mutation table is updated less frequently and all, so if you have data, you can build your machine learning tool. You have a scope to identify new mutations, that some of the samples for which the misclassification in diagnosis is happening, by genotypic DST, you would be able to address that question. And of course, these mutations can be linked to the mechanistic basis by some of the other structural or biochemical analysis. So this brings to me to the end of my talk. So that is the summary. So what I say, a machine learning based approach for antibiotic resistance, TBAMR PAID, has been developed at this one, and these are the sensitivity, specificity. So what this tool is, we have taken data set from BVBRC, that is the training, all the data which was there in cryptic, which we did not at all use in the training, and this validated on the cryptic data set. And we have also compared to the mutation table, and in streptomycin it is detecting many other mutations. So with this, I will stop and take questions if you have any.
Thank you, sir. So thank you for your nice talks, sir. So actually, there are two talks which happened today, so which are complementing each other.
Okay.
Like Dr. Camellia highlighted the clinical applications of
Sure,
sequencing
sure.
in TB,
Yeah.
which helps in enabling rapid drug resistance reduction, personalized treatment, and improve public health strategies. And your talk focused on the basic science of TB using structural biology, machine learning to understand molecular mechanisms and drug resistance. So,
Yeah.
like sequencing enhances the real-time clinical decision making. Like the computational models which you told will help in refining our understanding of
Yeah.
TB pathophysiology.
Yes, sure.
Like these two approaches are interconnected, like with basic science informing clinical advancements and
Exactly.
improving the predictive models.
Yeah, yeah.
So also like in this World TB Day, like they announced the completion of the 10,000 TB samples
Yes, we are
sequencing.
working along with Camilla and the
Yeah,
Dr. Sonali and all. So this is why it is important that we
yeah.
all, both laboratory scientists, clinicians, machine learning people, we work together. So we would be able to address things better. So
And also like Indian mutation catalog is also
yeah,
available on the NIRT
ICMR.
website.
Yeah, yeah.
So that also will add value to this existing new data.
Sure, sure, sure.
So if there are any questions, we can take.
Well, good afternoon, everyone, to this post-lunch session. I would just start by introducing Dr. Nishit Agrawal. Dr. Agrawal is a professor at the Translational Health Science and Technology Institute, Faridabad. His research focuses on the regulation of gene expression in MTB, mechanisms of drug resistance, and host-pathogen interactions. He has a lot of experience in identifying and characterizing new drug targets and studying drug-induced phenotypic tolerance. Dr. Agrawal completed his postdoctoral fellowship at Johns Hopkins and holds a PhD in biochemistry from Delhi University. Over to you, Dr. Nishit.
So thank you very much, Dr. Sanjay, and I would like to thank the organizers for reaching me out and allowing me to present my work in this forum. So today I'm going to talk a little bit differently than what we have been hearing so far. So the title of my presentation is The Development of Novel TB Therapeutics, Achievement and Challenges. So just a minute. Yeah, so I will begin by showcasing some of the challenges which we all are well aware of, that we experts feel in the field for management of TB. So if we can see that largely it involves four different areas: the therapeutics, diagnostics, vaccine, and patient care, and each of them carry their own challenges. For example, in case of therapeutics, we have all heard about how the prolonged treatment duration is causing the adverse side effects and the non-compliance leading to drug resistance. Also, there are LTBI, latent TB infections, which are very difficult to treat along with the persisters. In case of diagnostics, we know that the tools which we currently have, primarily which involves the molecular tools as well as the image-based microscopic tools. But although it is considered as gold standard, but as was mentioned, it's not as gold as was expected, and it leads to a lot of false negative. We still find difficult to detect all the drug resistant cases, and definitely there are challenges to detect extrapulmonary TB. Regarding the molecular tests, they often produce false negatives, so they are not supposed to be used for diagnosis of TB other than the drug resistance. Highly expensive, so countries like India, it's challenging to afford these tests, and they have the limited applicability for certain mutations. And again, extrapulmonary TB is a challenge. For vaccine, we do not have any other vaccine in since last 100 or so years. There are few candidates in pipeline, but the results are still awaited. And that is why BCG is only given to prevent the childhood meningitis, but it doesn't show that much of protection in the adults. And it's not also considered safe in the immunocompromised individuals. I will not touch upon the patient care. We have talked a lot about that. So what are the expectations, for the better management? So in case of therapeutics, we are expecting therapies which can shorten the duration, of the treatment from 6 months to 9 months to few months, so that we can avoid the side effects and, we can expect more adherence to the treatment. Also, we expect to have the treatment for latent infections so that we can prevent the reactivation. We need molecules with a new mechanism of action. And as mentioned earlier in the today's presentations, we need also to look at the personalized medicines option. For diagnostics, we again are expecting the cost-effective and rapid diagnostics point of the care tests, which are not available for tuberculosis. For that, we need to work on extensively to find out the utility of the new host and MTB-derived biomarkers, so that we can, and then very importantly, if we can develop tests which can be used by using the, non-invasive manner, using the body fluids such as urine and saliva, and which can diagnose efficiently the pulmonary TB and extra pulmonary TB cases. So these are the wish lists. Definitely there are challenges, but this is something what all of us aspire for. Similarly, for vaccine, we aim for having vaccine which can elicit long-term memory response and which is effective and safe in immunocompromised individuals. So since today's my presentation is focused on the therapeutics, so I will continue on the same line of the therapeutics. So how the therapeutic pipeline, workflow is. So basically, when we talk about the TB therapeutics in the lab, development of TB therapeutics in the lab, there are two major, pipelines available. One is the target-based identification, and another is the phenotypic identification. So in the target-based identification, the primary, step is to identify the targets which we believe that they are the good targets to screen the molecules, and then based on the availability of the structure or the assays which are available, we then prioritize those targets and go for the screening of molecules to identify the hit molecules. And by multiple cycles of the step, then we come up with the lead molecules which we can test in the animal models as well as in the cell-based model. Whereas in the case of phenotypic screening, we start primarily by screening the molecules blindly against the pathogen or the surrogate of the pathogen, such as there are few auxotrophic strains available. So I will give make some presentation on our own experience with that. So by doing this, we again identify hit molecules, and the rest of the workflow is same, except that once we have identified molecules, now it comes to the target identification by creating mutations. And once the target is identified, we try to understand its mechanism of action. So I have basically uh, divided my presentation in 4 different facets, and I will begin by identification of new drug targets. So if we look at the genome sequence of Mycobacterium tuberculosis, which was published several years ago, we find that there are around 4,000 genes which are present in the genome, which encode for proteins. And approximately 25% of them, the function is not assigned well. And also by using the transposon site hybridization technique, it was identified that around 500 genes are involved in some essential functions in the bacterium for the in vitro survival. So the question which we began asking several years ago was that how to identify whether indeed these genes are essential or not. So there we developed this indigenous technology at that time, 2015, what we call the CRISPR interference. Now it is very much in use all over, in the different pathogens as well as, in Mycobacterium as well. So here what we do is that we basically have mutated the Cas9 into a dead Cas9, and that dead Cas9 was able to block the movement of RNA polymerase. So we momentarily get the silencing of the transcription, because this dead Cas9 and the guide RNA expression was put under the inducible promoter control. So this is the workflow. So here we have created the, all the guide RNA pools against all the 500 genes. Then we express them in the cells along with the dCas9, and then check the effect on the growth by using the, spotting these strains on the plates in the absence or the presence of the inducer. What we have used here is N-hydrotetracycline, which is or we call ATC. So something like this we see here, if the gene is essential, like some of the genes are right from the beginning of the first gene in the genome, DNA A, in the sequential order I've shown here. So if there are essential, then there will not be any growth on the ATC containing plates. So likewise, we have screened all the 500 genes in the strains, for essentiality. And what we have identified, roughly around 80% of the predicted essential genes were showing good defect of growth on the ATC containing plate, indicating that these are indeed essential and can be prioritized for screening of molecules against them. So we have also created this repository at the at the institution with the help of Department of Biotechnology, and these are some of the recipients who have received this tool, not only in India, as you can see, they're being distributed all over the world. So apart from that, we have also created another sophisticated tool wherein we can basically knock down virtually any number of genes as possible. But here in this cartoon, I'm showing the 16 genes together. All these, these are the sigma factors. So 13, there are 13 sigma factors. So 12 sigma factors other than the essential SIG-A were knocked down together in the cell. And these led to the robust downregulation of all those 12 sigma factor genes. Apart from that, we have also created a tool for editing the genes, although the editing is not as efficacious as found in other organisms, including the gram-negative bacteria. But using this tool, we could predict a gene which was falsely annotated as essential, that it is not an essential gene. And as we can see, the frame shifting, and that led to the complete change of the frame. This is a MICP3, which has been annotated so far as an essential gene, as shown in this microbrowser database. Another gene which was which encodes for the membrane protein was also predicted essential, but we were able to disrupt. But unlike the MICP3, this particular mutant was showing very, very slow growth. And when we looked at the colony morphology by the electron microscopy, we saw a significant perturbation of the cell envelope, which indicated that this particular membrane protein is very much required for bacteria to maintain the proper cell envelope integrity, as well as which is, essential for its regular growth in the culture medium. So once we have identified, genes which are showing significant growth defect upon silencing, we moved on to the target-based screening of inhibitors. So for this, we picked a protein called the CLIP-C1. So it's a very important unfoldase of the casinolytic protease machinery, and it is absent in humans. So it is considered as a good target for screening of molecules. Not only us, there are a few other research laboratories in the other part of the world. They are also working on targeting, this protein by the library which they have. So we have shown that it is very important for bacterial growth, not only in vitro, but also in the mice. As can be seen here, less granulomas were found in the mouse lungs when the mutant, when the doxycycline, which mimics the anhydrotetracycline, was given to mice infected with this knockdown strain. So we collaborated with medicinal chemist Dr. Sandeep Sundaryal at the BITS Pilani, and with the help of our colleague, my colleague Dr. Ramandeep Singh, we screened molecules which he obtained from the NCI and identified hits, which were showing more than 50% suppression of the protein. The enzymatic activity which we used here was the ATPase activity of CLIP-C1. And subsequently, we identified the MIC of these molecules against Mycobacterium tuberculosis 37RV. And what we found that one of these molecules, NSC10010, was showing a very good, MIC, which was in the submicromolar range. We also showed that this molecule interacts with the CLIP-C1 by the biothermometry interference approach. So then Dr. Sandeep Sundaryal took over, and then he synthesized this molecule, and the synthesized molecule was also showing more than 70% inhibition of the ATPase activity, as well as the in vitro protein degradation activity. So he did some structure activity relationship. Just to summarize, so what we have found that the methoxy group at position 6 is essential. And, bisquinoline chemotype is very crucial. So if we remove one quinoline chemotype, then the MIC is increasing. However, the linker flexibility, we did not find causing much effect on the activity of this molecule, but the electron withdrawing group were very, very important. But unfortunately, when we tested this molecule against the mammalian cells, we found it very, very toxic. And here our project stopped because we were not having funding to continue with this. Hopefully in future, when we will get more funding, we will like to explore more derivatives of this against CLIP-C1. So coming back to the third portion of this talk, which is the phenotypic screening of inhibitors. So this, library we obtained is a repurposed library which we commercially obtained, and it's an FDA approved library. So one good thing with this library is that this is already in practice or approved for use in humans. So it contains a variety of molecules, and we tested. Here we have used an oxytrophic strain because screening these many molecules in the BSL-3 was little, problematic for us. So we use this oxytrophic strain, which is approved as a surrogate strain in lieu of virulent pathogenic MTBS7RV for screening purpose. So we identified somewhere around 500 molecules showing good efficacy at the 50 micromolar concentration against this oxytrophic strain. And when we determined the MICs of the compounds, we came across 8 molecules as shown here, which were showing MIC at 20 nanomolar or less than that. So that was quite impressive. And out of those 8 molecules, 7 were already have already been used against mycobacteria, or they are in the clinical trials, different phases. So those are the known antibiotics, except one, which I have given a nomenclature of THS2903. So this was the molecule which is not known for its antibacterial activity per se, and not any antimicrobacterial activity. But what we found was that compared to INH, this was showing MIC at the 15.6 nanomolar. Not only that, we also showed that it is significantly killing the growth by the CFUs as well as the intracellular growth in the THP1. Okay. But again, as a setback, we found that this is not active against S37RV. So we've tested this molecule against MTB S37RV, and we found that both RF and INH were showing this strain was showing susceptibility to those drugs, but no effect was seen against this molecule. And similar was the effect against BCG as well as other strains of mycobacteria. So then we went back to the oxytroph, and what we found that when we expressed the LeuCD in this oxytrophic strain, which encodes for the endogenous synthesis of leucine biosynthetic enzymes, then we lost the efficacy of this molecule. So this clearly indicated that this molecule is somewhere blocking the uptake of leucine, which is an important requirement for the growth of this oxytrophic strain. So we again changed the strategy, and this time now we have re-screened these molecules against the bacteria expressing the leucine, as well as those which were not expressing LeuCD. So the idea was that if we see molecules which are showing the inhibition of the strain, the parent strain 6206, those will possibly block the leucine uptake, as I showed earlier, whereas those which are not showing any effect against the 6206, but now they are showing effect by overexpressing the LeuCD, will likely target the L-leucine biosynthesis, as well as the molecules which are showing effect against both means that they are at least not blocking the leucine uptake, which is a pseudo condition provided to this particular strain. So we identified 2 molecules which were not showing any effect against 6206, but they were showing effect against the bacteria expressing LeuCD. However, when we repeated this, we found these 2 molecules the similar pattern. But what was surprising that these were also showing effect against the BCG. So we do not know what is the particular reason about this particular phenotype. But definitely we have got several molecules which were inhibiting all the 3 strains. So currently we are trying to explore them and trying to sequentially identify their mechanism of action. So now coming to the challenges and expectations. So here I would cite a real case scenario from the industry experts. So this is a paper which I found very interesting. It comes from the Novartis Institute of Tropical Disease. There, the first-hand experience was given in this paper, and this indicates that what kind of challenges we, as the basic researchers in the lab face. So this is about target-based as well as the phenotypic screening of the millions of compounds. And as you can see in this particular chart table, that none of the target-based screening efforts led to the generation of the lead molecules for variable reasons. So this took a lot of time to identify that these efforts are not so fruitful as expected. And at the end, we do not have any molecule which can be taken forward for the preclinical trial. How the phenotypic screening yielded, few hits, but as you can see here, the hit numbers were very, very less. So so there were 3 campaigns run. In the first 2 campaigns, there were 2.2 million compounds were screened against both BCG, which were later verified against MTBS37RV. Whereas the third one was started with the MTBS37RA and again verified in the RA only. So hit rate was varying from 0.27% to 0.79%. And all these 3 campaigns involved the 3 different group of molecules. One was the pyrimidine imidazoles and imidazopyridines. The campaign 2 involved the pyrazolopyrimidines and indole carboxyamides. And the campaign 3 involved the pyridones. So in this, summary of hit, when they checked the different MICs, the only 7% molecules were found to give MICs less than 0.1 micromolar. That too was the MIC 50. However, this number was further reduced to less than 1% when the known anti-TB chemotypes as well as other molecules showing the lipophilic compounds or the large natural products were removed from this collection. So as per their statement, their overall experience was not that was that only a very small proportion of the TB phenotypic screening has hits had ideal lead-like characteristics that would generally be sought by the medicinal chemists to initiate the optimization. So what are the challenges? Some of the challenges, which we encounter. The first one is that it's largely empirical and driven by feasibility of synthesis, because at the end you have to take help of the medicinal chemist for the synthesis of molecules. And so thereby you have to keep that aspect in mind while prioritizing the lead molecules for, further testing. Secondly, what we very often see that, changes in the cell and permeability or efflux of the compound is not taken into account while, optimizing the molecule by the synthetic chemist. So, but this is the reality, and that is where, again, the molecules often fail when they are synthesized. And it has been seen that, multiple diverse chemotypes, they lead to the generation of mutations in the targets which are residing on the cell envelope, such as the MMPL3, DPRE1. Many mutations have also been seen non-specifically in the ATP synthase as well as the energy production QCRB. So therefore, it remains a question that what is the exact mechanism of action of these molecules. Secondly, thirdly, that very important factor is the growth medium. So as a general rule of thumb, we always tend to start with the standard growth medium, which contains plenty of glycerol and glucose. But in one case, they have reported that this is a group of 2 molecules which they have prioritized based on their phenotypic screening, showing a very good MIC in the regular culture medium against S37RV in vivo, which was equivalent to INH. And also the serum level was quite high above the MIC levels in the mouse. But when they tested the effect in the mouse model of infection, there was hardly any effect of both the molecules compared to INH. So this was very perplexing. But then after long, multiple experiments, they found out that both these molecules fail when they are checked in the medium without glycerol. So what came out that, these glycerol is actually that produces the byproduct, which is very toxic. And somehow these molecules, they interfere in the detoxification of those toxic molecules in the pathogen. And therefore, the toxicity of these molecules is because of the accumulation of this methyl glyoxal rather than inhibition of any particular target. And because bacteria do not encounter glycerol during the in vivo situation, and therefore these molecules do not show any effect in the during in vivo condition. So this is my last slide where I've summarized what are the challenges and what we can expect as a lab researchers. So as I showed, we encounter very high rate of failure during initial screen, both in vitro and in vivo condition. This entire journey is very much time consuming. Often it takes as long as 10 to the 15 years. And a lot of cost is involved because of the failure. And this cost also taking into consideration when the molecules pass all those journeys and then they are ready to launch in the humans for the preclinical. Then also a lot of money has to be put for a trial. So overall, it is not a profit-making venture which can attract industries, and without industrial support, it is very difficult to expect this kind of funding and support from the other funding agencies to carry out this venture. And therefore, as I mentioned, this inadequate support again puts us on the in a difficult situation. And also, when the molecules which have crossed all these barriers, the approval for them is very lengthy. So it has been reported that for molecules like even bedaquiline also, it took several years to get approval for before it was approved for use in humans. So what we can expect, because this meeting is about preparing some, white note for the future recommendations. So we are expecting that there should be a mission mode program nationwide for TB drug development against indigenous isolates. Many times these, drugs come from the against screen from the isolates from other parts of the world. But we, as now the government of India has started sequencing these indigenous strains. So we will come to know the specific, phenotypes and the genotypes of these strains, which might be very characteristic of the Indian subcontinent. So we need this mission mode program for the TB drug development. This drug journey also fails because of, and not only drug, I will say, rather even the vaccine also, because we feel handicapped because of the absence of the appropriate models. So it is expected to have the few facilities with the BSL-3 non-human primates, or these controlled human infection model is the buzzword. So hopefully this has shown some hope after the COVID, and hopefully this will also fuel some pace to the TB research in terms of drug evaluation of the drugs as well as the vaccine. We need to bring various stakeholders on board. So at present, it is difficult to expect anything significantly coming out of our efforts without bringing clinicians, without bringing industry partners and academicians together and make a thorough plan and brainstorming and devise the way to basically develop a few programs which can be helpful in this direction. We also have to create the funding mechanisms. So we have seen cases where the people are struggling with the molecules which are ready, which have passed the phase 2A trial, but now they're not getting support for further trials. And if that would be the case, then we will lose the zeal of getting anything meaningful coming out of our efforts from this country. As again, the same, like we have to facilitate the preclinical studies by creating mechanisms for the molecules which are ready to launch. And we should also look at the policies, how we can revise to expedite. We have seen that during COVID time, and that has actually helped, managing the COVID pandemic very well. So I will end here, and I will be again very much thankful to all of you for your patience, and I'll be happy to take questions if there are any. Thank you.
Thanks, Dr. Nishit, for that very insightful talk. And I think thanks also for managing the time. I know there is one hand up, but I had one quick question. Given the challenges specifically, for both of the areas that you have explored, that is target-based as well as phenotypic screening. Do you see any utility for artificial intelligence-based computer-aided drug development models? Because that is something which is increasingly coming into play. And as you saw in most of the cases, that significant amount of work was done, and then it was found that the target was not necessarily active against the bug. So do you see any scope of that?
Yes, we definitely see. Basically, if you if you look at the what are the workflows. So one of those workflows involve the target-based screening. So basically, why we fail often, that in the long journey, when we after crossing several miles, we realize that the targets which we were anticipating are useful targets are not going to be useful. So the AI can definitely help in that direction to basically prioritize the targets against which the molecules can be screened. And that thankfully now we have a lot of repositories and databases which provide varying information about each of these genes which I've just talked about. So I feel that yes, incorporation of AI-based information and development of newer tools can be really helpful in this venture.
Thanks, Dr. Nishit. I think there is a one hand up, Dr. Varada.
Hi, Nishit. Really nice talk. I enjoyed it. And thanks also for pitching in strongly for the concerted efforts for drug discovery. I had one quick question. You mentioned about screening indigenous strains, right? Do we have strong examples where the MIC varies substantially between different clinical strains? And if so, do we know some basis for that?
Yeah, so that's a very good question. So per se, I think that I will not be the right person to answer for that. But my feeling is that there are selection pressures coming from the humans and the population. So basically, and then the kind of mutations which you see in the field. So you may see prevalence of particular mutations in the Indian subcontinent compared to if you compare with the African or the Brazilian continent or elsewhere in the world. So definitely the kind of mutations which we see might drive what kind of priority drugs which you have to, or strains which you have to focus on, number one. And secondly, definitely there is a selection pressure coming from the humans. So and there are several papers on that lines which basically talk about the accumulation of mutations differently in the different places. So that now the genome sequence efforts are going on. So definitely time will be there come that when we will know about differential susceptibility there or not. But I feel that there is a likelihood of that prospects. Yeah.
Yeah, I completely agree. And just add to that point, I think we should probably also, for a large scale drug screening campaign, you cannot obviously screen on so many different strain, right?
Great.
So
Agree.
therefore, on the other hand, screening it against something like RV might lose the local context that you are mentioning.
Yeah.
So I think this is an important point that is going to require consideration going ahead.
Yeah, so I mean to say here that, definitely you are right that we cannot involve multiple strains even if they are coming from India. But I feel that the strains which are well comfortable, for Indian people and they are infecting them, what should be the preferred choice, considering that I'm talking about the wild type strains without any mutation as the reference strain. Because we all know that RV we use, just for the feasibility purpose. But when it comes to the growth pattern, it shows totally different behavior than what we see with the clinical isolates. So that is another thing which we have to prioritize, that how to start from the right strain, and that to the strain which makes better sense for the country, rather than using something which is, yes, well cataloged, but not the choice, or could be the choice of the strain for this particular exercise.
Just one last point
Yeah,
from my
Dr.
side.
Bharat, in the interest of time, I'll request you to maybe talk to Dr. Nishit offline. We are significantly behind schedule.
All right.
So if you don't mind, there's another question for you, Dr. Nishit. Perhaps you could care to respond to the question in the chat itself.
Yeah, I will.
And meanwhile, I'll move on to the next speaker. I would take the opportunity to introduce Dr. Raghunan Thirumalai. Dr. Thirumalai is a senior principal scientist at the Center for Cellular and Molecular Biology. He focuses on host pathogen interactions in MTB, identifying mechanisms of drug resistance. His work explores the molecular mechanisms of underlying MTB persistence and its response to antimicrobial stress. Dr. Thirumalai, over to you.
Hi, can you see my presentation?
Yes, we can.
Okay, let me just see if I can this properly. I can't see it. Someone can help me. I'm not doing this properly.
We can see the.
You can see my PowerPoint?
Yes, it says host pathogen interaction, right? Drug resistance and yeah.
Combating.
Yes.
Is it my? It's
yes,
my.
Yeah.
You can. Okay, but I can't see it on the Zoom screen. But then I'll run it on my. Since you cannot see it, I will run it on my PowerPoint. You can all hear me properly?
Yes, we can.
Okay, wonderful. thank you to the organizers, Dr. Sarkar and Dr. Babu, for inviting me to this wonderful meeting. And I look forward to the proposed meeting in August, where we will meet in person to discuss facets related to TB eradication. Also, it turns out that 3 speakers in the post-lunch session, Nishith, I, and Vidya, are all from Hopkins. So it's a pretty cool thing. But I was asked by the organizers to give a basic perspective, basic science perspective of eradication of TB. And I'm going to share a little bit of work that we've done. Just little snapshots of our work, which started off being basic in nature, but it turns out that they have potential applications. And then we will go on to what I think should be the road ahead based on my own perception of work in this area. So we study the basic biology of the pathogen and its interaction with the host, with our hope that this will lead to the discovery of drug targets or diagnostic modalities or prophylaxis. And the 3 major areas that we are focusing on are host pathogen interaction, drug resistance, and pathophysiology. And I will give you little stories from each of these, which we started off based on our interest in studying the biology, but it turns out there may be potential applications of what we've done over the last 17 years now. So the first story is on a calcium binding protein called DES-A1, which we started totally by accident, because I had a colleague, Yogendra Sharma, whose lab worked on calcium binding proteins. And he came to me one day and said, why don't we look and see if there are any calcium binding proteins in the MTB genome? And the group of calcium binding proteins that he was interested in were called beta gamma crystallins. So we did a search for beta gamma crystallins in the MTB genome, and it turns out there are 3 of them: LPPM, UBIA, and RB3 at DES-A1. And it turns out that DES-A1 was a desaturase predicted to catalyze the introduction of position-specific double bonds during mycolic acid biosynthesis, which is a class of lipids present in the cell wall, which is a very popular target for anti-TB drugs. And this DES-A1 protein had a predicted beta-gamma crystalline Greek key motif, which the figure is shown in this. I don't know if you can see my pointer, but the figure shows you the Greek key motif, which is present on a lot of pottery if we go to Greece. But we were interested in this because we wanted to see if this binds calcium and if the beta gamma crystalline motif is actually the motif that binds calcium. And a postdoc in my lab, Veena, showed after many excruciating years of work was that DES-A actually binds calcium, and we could show this using a calcium 45 overlay assay plus isothermal titration calorimetry. And followed by this, we decided to dissect the calcium binding motif. And Mamta in the lab made several mutations in the calcium binding motif and showed that if you disrupt this calcium binding motif, calcium doesn't bind. And then Ravi in the lab started to see if this has any phenotypic consequence. And we used a conditional DES-A1 smegmatis mutant, which was given to us by a friend and former colleague Apurva Bhatt in Birmingham. And we showed that if you try to complement the growth of this conditionally complemented DES-A1 mutant with these point mutants, you couldn't recover the phenotype if these didn't bind calcium. And also there was a permeability defect, and there was a change in lipid content as well. So we concluded from this study that calcium binding was critical to DES-A1 function and in the maintenance of mycobacterial cellular integrity. And since this was a predicted essential gene, we hypothesized that this is a potential drug target. And the hypothesis is actually borne out by Apurva Bhatt's lab because they could only make conditionally complemented mutant in M. smegmatis. So we went forward with this and tried to see if we could design inhibitors against DES-A1 using an AI/ML approach. And for this, we collaborated with a company called Aganitha Cognitive Solutions. We have an MOU with them now. So The folks at Aganita modeled the DESE1 structure using AlphaFold, and they did MD simulations to see what were the pockets that could accommodate ligands, and then they did virtual screening of this modeled structure against focused ligand libraries. And they've discovered 4 FDA-approved drugs as hits for this structure. And they went on to do MD simulations and showed that despite fluctuations within the large active site, all 4 candidates actually exhibit strong binding. So we've now purchased all of these drugs, and we are in the process of actually checking whether these affect the function and activity of DESE in vitro screen. So although this started off as a fun exercise where we were trying to just look for calcium binding to DESE1, it turns out that we might be onto something as DESE1 as a drug target, and we already have some molecules that might actually inhibit this protein, specifically in the calcium binding site. Now, the second story involves identification of regulators of macrophage apoptosis in MTB, and we got interested a few years ago in this because one of the family of proteins that we were looking at, this is called the PEPP family of proteins, contained potential binding sites for a protein called caspase 3, which is involved in apoptosis. So brief introduction of apoptosis and how apoptosis controls infection in the body. So there are 2 kinds of processes in apoptosis, intrinsic apoptosis and extrinsic apoptosis. And this is a mechanism designed to kill infected cells via the activation of the immune system. Both of these processes involve proteins called caspases, which are cysteine and aspartate proteases. There are initiator caspases, which activate what is called the executioner caspase, caspase 3, which leads to killing of infected cells. Now, MTB is very clever. It has the ability to suppress apoptosis and induce necrosis. And this is shown in this cartoon over here from a nice review written by Maziar Divangai. And here we see that when a macrophage is infected with an attenuated strain of M. tuberculosis, this leads to apoptosis, restriction of bacterial replication, phagocytosis of apoptotic vesicles, and then cross-priming, leading to activation of both CD4 positive T cells and CD8 positive T cells. Now, to prevent all of this and favor its own survival, virulent MTB is able to induce phagosomal damage, translocate to the cytosol, and induce necrosis of the infected macrophage. And of course, we know that when MTB emerges from infected macrophages, it can infect other bystander macrophages, and there the infection cycle goes on. So obviously, MTB has a lot of proteins that can do this, and some of these are known, but their mechanism of action is unknown. So we hypothesized that there must be MTB-encoded proteins that inhibit apoptosis by interacting with either initiator or executioner caspases. So we picked caspase 3, which is the executioner caspase, and caspase 8, which is an initiator caspase, and using pull down of lysates of infected THP1 cells with MTB H37RV infection, followed by mass spectrometry, we were able to identify 2 candidates, one that interacts with caspase 3 and one that interacts with caspase 8, and we have validated their interaction. And we are now making either knockdown strains or knockout strains based on whether they are essential for growth or non-essential for growth, and trying to functionally validate their role in apoptosis. And the expected outcome could possibly be that we may have an improved vaccine candidate, or we could have an anti-infective inhibitor. This is all in the future realm, but there's something that has potential applications. The third and final story involves identifying genes involved in carbapenem resistance in MTB. And this is part of our program for understanding mechanisms of antibiotic resistance in MTB. And we are primarily asking 2 questions. One is, can we discover new mechanisms of resistance? And that is based on the premise that all mechanisms of resistance have probably not been identified so far. And the second is, can we look at mechanisms for tolerance or resistance towards repurposed drugs? And there we are specifically looking at beta-lactam antibiotics. So why are we interested in beta-lactam antibiotics, and why are they important in the context of TB treatment? Now, it turns out, and many of you will probably know this, is that MTB is intrinsically resistant to beta-lactams because it has a highly active beta-lactamase and it has poorly permeable outer membrane. But it turns out that there are a class of beta-lactams, a third or fourth generation of beta-lactams called carbapenems. And carbapenems appear to be active against MTB, so much so that in combination with clavulanate, which is a compound that inhibits beta-lactamase activity, they are highly active against drug-resistant tuberculosis infection. So, and the WHO has earmarked them as potentially active drugs for the treatment of drug-resistant TB. So to stay one step ahead of the curve, we think that there's a need to examine possible resistance mechanisms against carbapenems. And we went ahead to try and see if mycobacteria encode any mechanisms that would make them resistant to carbapenems. And this is a workflow that we formulated, first using M. smegmatis as a proof of concept, and we have gone on to do this with MTB as well. So we took what is called a transposon mutant library approach to see if we could identify genes that are involved in carbapenem resistance. So we constructed a mutant library using the Mycomar T7 phage, and we generated a library of 30,000 TN mutants and screened those mutants on meropenem, which is a carbapenem that has been considered by WHO. And whatever colonies appeared on plates, we picked them up, subcultured them, and proceeded to do genome walking to identify what was the site of insertion. And of the 3 hits identified, we proceeded with one of these, and we call this HV13, and it turned out to be a gene called M. smegmatis 2772, which encodes an amino acid transporter. And we took this forward and looked at what the specificity of the resistance phenotype of this mutant was, in addition to it being resistant to meropenem. And it turns out that this mutant is resistant to isoniazid as well as rifampicin. And strangely enough, it showed collateral sensitivity to streptomycin. Now, we don't know exactly what the mechanisms of all of these are, but we've done complementation of the mutant with the smegmatis gene and the TB gene, and we've found phenotype reversal. And we're now interested in taking forward these results to see what the mechanism of action of this transporter is. And here's a working model that we have. We think that this transporter is involved not only in bringing in amino acids, but also possibly in bringing in antibiotics like meropenem or RIF and INH. But we have to experimentally confirm these by doing some biochemistry, which we're doing. We're interested in understanding the structure. And also now we're generating an MTB knockout of this and screening MTB transposon libraries for resistance. So the outcomes we think might be identification of novel resistance inhibitors, because we have a lot of other hits which we are characterizing presently. And this might be able to, this approach itself of using transposon screens to identify resistance genes might lead to the identification of diagnostic markers for drug resistance. So what do I think is the way forward? The first thing, I think basic science and basic scientists can play a role in TB eradication. Would be one, can we look at drug repurposing? And Nishit in his talk alluded to some of their efforts in testing this. Can we test all FDA-approved drugs in multiple models of TB infection? This would include in vitro grown TB, TB in macrophages, and TB in multiple animal models, possibly even things like marinum in fish models. But that's an enormous effort which would require a lot of investment as well as people. Second, I think some of these approved drugs would be host protective, and that gives us the opportunity to look at host-directed therapy. And here I would like to draw your attention to this wonderful piece of work done by Vivek Rao and Sheetal Gandrotha's lab at IGIB, where they showed that sertraline, which is an antidepressant, actually has fantastic host-directed a protective role in MTB infection. And this is something that we should push forward. There may be many molecules like this which need to be taken forward to trials, and there should be a push for this. Again, alluding to what Nishit said in his in what we propose for this effort. Next, I think we should look at antibiotic resistance mechanisms. And we know from clinical studies that we haven't yet looked at the entire genetic repertoire of resistance in MTB. And we could use multiple approaches, including approaches like the one Nishit has invented, the CRISPR approach, or a transposon mutant library approach. And this could lead to potentially the diagnosis, different markers for diagnosis of drug resistance, identification of new genes, which could be which could then feed into the targeted genome sequencing approach, which Dr. Camila Rodriguez explained in such great detail this morning. And this could also lead to the discovery of molecular bodyguards, like we have in the case of Augmentin. Augmentin is amoxicillin plus clavulanic acid, and clavulanic acid inhibits beta-lactamase, making the treatment of amoxicillin resistance infections possible with Augmentin. Then, as was alluded to by the chairperson, can we use AI/ML to identify lead compounds? I think we can. We're just scratching the surface on what AI and ML can do for us. And we know this from a beautiful effort pioneered by J.J. Collins at the Broad Institute, where they used such tools to train AI/ML models to identify inhibitors that inhibit both gram-positive and gram-negative bacteria. So you could end up screening millions of molecules in a virtual library. And to make things better, you could only screen libraries which can be synthesized, which is a challenge, like Nishit also mentioned. If you need to synthesize something, that can be a challenge for synthetic chemists. And these could be targeting essential genes or pathways. Now, there are two kinds of essential genes. Nishit talked about in vitro essentiality, but there are also in vivo essential genes which can be targeted for such things. And finally, I think we need a countrywide population-based study on disease resistance / susceptibility. We have not seen a study like this looking at either resistant populations or susceptible populations, where we get a chance to look at genotype and phenotype correlation of MTB strains. Again, something that Nishit mentioned, looking at indigenous circulating strains. We know from the DBT effort for the first 10,000 sequences that the primary strains that are circulating in India are L1 and L3. But there may be others as well, and they may be specific to certain regions, and their susceptibility to antibiotics and their virulence characteristics may be different from the ones that we are testing in labs. So it's very important that we have a study like this, and we also look at host immunogenetics, where we try to correlate if there is a link between the kind of strain circulating versus the kind of genetics of the population in a particular region. And this is a project that will actually bring a lot of people together, and a lot of talks in this forum have said we should bring stakeholders together, we should bring different kinds of people who work against TB eradication in this. It could be researchers, clinicians, epidemiologists, public health workers. So we need to build and investigate a network, pool our resources, and work on a national grand challenge. And this has not happened in the last several years. I keep saying this in multiple fora, but this is something that we must make happen, that we pool resources. We can't continue to work in our silos. And unless there's a concerted effort where we all work together and work on a bigger problem at a bigger scale, eradication is going to be a huge challenge. So we could have multiple conferences like this, but we may end up not making a dent at all because we don't pool our intellectual and physical resources. So I will end my talk with this quote that was made in this very nice editorial that was published in 2022 by Valerie Mizrahi and Digby Warner, etc. And they say we should address TB as a systemic challenge. And let me quote from this. They say that the TB field is organized around specific research thrusts that, albeit delivering important advances, have struggled to cohere in addressing TB as a systemic challenge. Reframing the TB narrative while collapsing barriers among TB researchers will be critical if transformative progress is to be made towards ending the TB epidemic. And I'm sure you'll all agree with me that it is time we start working together, because this is a challenge that only people working together can solve. Thank you very much.
Thank you, Dr. Sirumalai, for a most interesting talk. I think all of the three concepts that you're exploring, they have a lot of potential. I just had one quick question, because I don't see a hand up. Specifically, the third piece of your talk, which was around identifying genes and causing carbapenem resistance. Do you think this could have any potential applications, looking at other bugs like the CREs and crabs? Because, carbapenem resistance is really wreaking havoc as far as AMR in general is concerned.
True. It is possible there may be homologs of the genes that we identify in these other bugs as well. And we tried to do a phylogenetic analysis, but we haven't done that very well yet. But it's possible that many of these transport proteins, especially efflux pumps, which do the job of pumping the antibiotics out, many of these are conserved across bacteria, irrespective of whether they're archaea or eubacteria or anything else. So efflux pumps are conserved, and many of these are ABC transporters. So we are also looking at efflux pumps and their role in resistance. So I cannot answer your question right away, but I think that there may be some overlaps in these transporters across bacteria. And if there is, and if one could identify an inhibitor, which would be like pan-pathogenic bacteria kind of inhibitor or a set of inhibitors, that would be really useful. But we need to do a lot more work before I can give you a proper answer to this question.
Thanks, Dr. Sirumalai. I know Dr. Nishit's hand is up. Dr. Nishit, in the interest of time, if I can request you to be brief.
Yeah. My only, very brief question to Dr. Raghu is that, have you looked at the mutations in this particular gene, RV2690C, in the clinical isolates?
We haven't found them yet. So this is a new transporter. I think we need to do a deep dive, and we might find something, but in our initial search, we did not find anything. But that's an excellent question. Perhaps we haven't looked deep enough.
Thank you.
Thanks,
Dr. Sirumalai. Thanks very much. I'll now invite Dr. Vidya Mave. Dr. Vidya has more than 12 years of experience in clinical practice, education and research in infectious diseases, and has published several peer-reviewed research publications. She joined the Johns Hopkins CCGHE and now coordinates all clinical research activities at the BJGMC and JHU Clinical Trial Unit, which conducts phase 1, 2, and 3 clinical trials. Over to Dr. Vidya for the next talk.
Thank you very much for the kind introduction. Somehow I'm not able to find my presentation, so let me find it and get back. Open that. It's on here. All right. All right. I hope that you can see my presentation.
Yes, we can, Dr. Vidya.
Thank you. I am going to give a brief overview of the TB clinical space and what are the factors for TB treatment outcomes, and a brief overview of the TB vaccine landscape and why we are considering therapeutic TB vaccines, and with the conclusion on this talk. This crowd is already very aware of TB treatment outcomes, which with the very advanced diagnostics and treatment regimens available are up to about 75 to 90%, with much lesser success rate among people with HIV. And among many of the factors which are responsible for poor treatment outcomes, the main factors would be the patient-centered factors, as well as bacterial factors, including presence of bacterial burden, excess burden, as well as cavitary disease. But what is in our hands at this time are whether can we achieve an optimal adherence among patients with TB. Therefore, we can achieve even better outcomes in regards of TB treatment outcomes. And this pool study called TB Reflect, which actually pooled individual patient level data from 3 fluoroquinolone trials, found that even one missed dose per week can increase the risk of bad treatment outcome by 2.4-fold. And of course, one of the key TB treatment outcomes which are considered here are TB recurrence. And we know that in India, about 10 to 20% of people who are treated for TB successfully do develop a second episode of TB. And in our own data, we found that this recurrence could be as high as 10% among our studies, cohort studies, from report and tuberculosis diabetes interaction studies in Pune, as well as Chennai. And among of that, about 20 to 40% could be a subclinical TB recurrence as well. And more importantly, TB disease can leave a permanent lung damage, which is being more and more recognized in the TB field, which can affect the quality of life of these participants.
A meta-analysis of studies
Excuse me.
evaluating the long-term consequences of TB have identified that in comparison to...
Could you hear me?
Yes, we can hear you, Dr.
Not had TB.
Yes, somebody needs to
Somebody
mute
needs
themselves.
to go on mute, please.
Yeah.
Post-TB, despite cure. The mechanism of the increased risk of death are uncertain.
All right. I'm not really sure what happened. Why
Is this probably associated with your presentation?
Maybe it is, yeah. All right.
With the audio file is embedded in that slide.
Yeah, that's probably is what it is. Okay. All right. Let me look for the presentation. Can you give me 2 minutes and maybe go to the next presenter and I can come back?
Okay, sure. We can.
Okay? Thank you.
We can go to Dr. Asha. Dr. Asha, if it's okay with you. So I'll very quickly introduce Dr. Asha Frederick.
Sorry. I also need some time because I've just.
Or Vidya, you could move to the next slide and see if that audio file is in the whole presentation or only that slide.
But appear to
yeah, it's probably only on that slide. Yeah, I'm not really sure why that happened. Okay, let me just come back and go back here, presentation mode.
You can't see your screen yet. Yeah, it's coming up now.
Can you see that now? Okay.
Yes.
All right. So global TB cases notification have been reducing, but it is far from what needs to happen to achieve our 2030 TB elimination goals. So some of the TB vaccine strategies has been considered to achieve our TB elimination goals. And in this modeling analysis, it was found that a TB vaccine, which is effective by at least 40%, can have a lasting effect, a durable effect for prevention of TB, which can last up to 5 years. If it is 60% effective, it could last as long as 10 years. And if it is 80% effective, it could be a lifelong protection against TB. So there are 2 vaccination strategies which are considered. One is a pre-exposure prophylaxis, which targets a population who are uninfected with tuberculosis, infection, or disease. And the target indication of prevention of infection or prevention of disease, while a post-exposure vaccination strategies includes prevention of disease among TB-infected participants or therapeutic or prevention of recurrence indications among those with the TB disease or those who have been already successfully treated for TB disease. So what are the consideration for TB, therapeutic TB vaccines? They include we need to administer these vaccines among people who are currently undergoing TB treatment as an adjunct to TB treatment, which we hope achieves or induces appropriate immune responses. And the primary aim is to individually benefit the patient, while the final aim would be to contribute towards population level impact. So this has been summarized in this slide about the characteristics of what a therapeutic vaccine should be, what would be the primary targets, and that would be to improve the cure rate, decrease the incidence of recurrence, while all of these vaccines have a favorable safety profile. And the target population could be anyone, including a drug-accessible TB, drug-resistant TB with or without HIV presence. And the long-term target would be to decrease the treatment duration and decrease the number of drugs and minimal repeat vaccination that would be required. And of course, we need to identify whether these vaccines can decrease the therapy duration, while we also identify an appropriate immune correlates of protection, and also perhaps have a biomarker which can help us identify whether optimal treatment outcomes were achieved even before an event occurs post-treatment. So is it biologically feasible to have therapeutic TB vaccine? We know that effective immunity results from a natural exposure. So there are some preclinical evidence with these two vaccines, which have been published previously, which looked into when compared to a standard of 90 days of isoniazid rifampin doses, whether survival of the mice are achieved with these kind of vaccines, and they were positively concluded. And the second study, which is a biological feasibility, was a clinical study wherein M72 vaccine were given to people with MTB infection and were followed for 3 years for development of TB disease. And there was a 50% protection achieved with this M72 TB vaccine against development of TB disease. So biological feasibility was also assessed in this meta-analysis, wherein MVAC TB vaccine was adjunctively given along with the MDR TB treatment. Only thing is that these studies were of very small and of poor quality, but when they pulled the data of 2,281 participants with TB, they found that it was effective with the smear conversion was decreased by 3.84-fold, and the cavity closure also was achieved 3-fold higher in those who received the vaccine. So the mechanism actions proposed for therapeutic TB vaccines include a host-directed therapy, would be achieved by modulating the immune response from a Th2 bias to a Th1 response to reduce extracellular growth of bacilli and to increase the efficacy of the chemotherapy. And vaccine also can be administered at the start of the treatment as well as soon afterwards, is what is shown in this figure on the right side. And similarly, whether killing the bacilli by boosting the immune response directed at the MTB bacilli may slow replication and reduce drug sensitivity using vaccines that express latency-associated antigens would be also achieved. And so the idea is that this vaccine could then be administered once the significant reduction of bacterial load occurs, maybe about 1 month into TB treatment. Therefore, duration of the treatment also can be potentially reduced. So currently, as compared to, say, a couple of years back, our vaccine pipelines are somewhat smaller due to some of the vaccines coming out of these pipelines because of unsuccessful attempt in getting vaccine efficacy for several of TB vaccines. which I'll discuss in a couple of slides down. But among these vaccines, which are in various stages of currently development through phase 1 to phase 3, only few vaccines have been considered or are being tried as a therapeutic TB vaccines. And all of these vaccines can be used for, multi-purpose indications, including prevention of recurrence or improving cure or simplifying TB treatment by potentially shortening the TB treatment. As I mentioned, for prevention of recurrence, currently ID93 is a protein subunit vaccine is being considered. H56 IC31, the trial has already been concluded in South Africa, and the results were not very promising. So likely that vaccine will come out of the pipeline. M72, as you know, will be developed further, and BPM-12002, which is a recombinant BCG vaccine, has also completed trial for POR, and results will be available soon, and we will hear about that very shortly. There are MVAC trial, Ambindicus prani, Ruti, H56, and ID93 for treatment. Some of these trials are ongoing, and I think Ambindicus prani is, I'm not entirely sure if the trial is ongoing at this time or not, but for MVAC, M3 trial, phase 3 trial is ongoing, and ID93, I will talk about it in a couple of slides down here. So what would be a design of a TB therapeutic vaccine design? Trials has been shown here in this cartoon, wherein potentially vaccination can be administered at the end of intensive phase of treatment and or at the end of treatment. If it is administered during TB treatment, it would be then considered truly a therapeutic vaccine as opposed to an end of treatment, when the indication would then become prevention of recurrence. And all of these participants then would be followed for at least 12 months or so to identify any adverse TB treatment outcomes, thereby assessing efficacy. One example is shown here, is that could we really do a time de-escalation? We can start a new TB vaccine, say if it required 2 doses, for example, for ID93 at month 4 and month 6, and identify there is enough safety profile has been achieved and that immunogenic responses are appropriate, then de-escalate to maybe month 3 and month 5, and similarly de-escalate to as low as month 1 and month 3 of vaccine administration. And in terms of outcomes, what would be the outcomes outside of clinical outcomes? Potentially, we could also look at whether vaccines can benefit in terms of post-TB lung disease, which remains impaired among 40% of the people with TB, whether vaccine immune reactions can reduce and act as a host-directed therapy in reducing this bad outcome. In addition, RNA signature potentially, which can detect those who would have TB disease progression or not, is still a holy grail, but that could be one way an exploratory outcome could be measured. So as of today, for therapeutic TB vaccinations, the WHO preferred product characteristic include it should be indicated for duration of protection from recurrence and should have a target population, could be those with or without HIV and those who may have drug-sensitive or drug-resistant TB, and that it would have it should be safe and immunogenic and have a good stability. Currently, there has been several trials, the 4 trials which are ongoing, or some of them have completed. The first 2 trial, BPM-1002, has completed enrolling as well as follow-up, and analysis is ongoing. This was a multi-center phase 2/3 double-blind randomized placebo-controlled trial, which wherein VPM 1002 was administered among those who have completed TB treatment for pulmonary TB and enrolled participants from Report India sites and several other sites in India, as well as Bangladesh. And H56 trial is again a similar trial, which included subunit TB vaccine H56 IC31 for pulmonary tuberculosis. And this trial also concluded follow-ups and enrolled 900 participants. And the results have been presented in several meetings wherein it will likely fall out of further development. An ID93 GLA-SE vaccine as a phase 2A/2B safety immunogenicity study will be conducted through the ACTG, NIH Network ACTG and HVTN collaborative effort. And this will enroll 1,500 participants with HIV positive, HIV negative, with drug-sensitive TB, and will assess adverse treatment outcomes. The information about RUTI is available for therapeutic vaccine in the clinical trial sites. However, details are limited at this time. We know that 140 people with HIV, with drug-sensitive or drug-resistant treated TB who have already been treated will be randomized to RUTI and placebo and will be followed for culture conversion in 2 months, as well as 6 months, and further details will be upcoming. Just to briefly show what we did for VPM 1002 in the prevention of TB recurrence trial, we enrolled 2,000 participants between the age of 18 and 65 years to either to receive a VPM 1002 or a placebo, and they were followed for 1 year for development of bacteriologically confirmed TB. And Report India participated in this trial in a massive way, not only in terms of execution, but also in the development of the study and trial design, and as well as undertaking many of the immunological work for this trial. And H56 trial also followed similar kind of schedule, where, however, only difference is that participants are enrolled at the beginning of TB treatment, as opposed to our trial where we enroll participants at the end of TB treatment. And this ACTG HVTN vaccine trial will begin shortly. Again, will enroll drug-susceptible TB who will receive vaccine anywhere between month 1 and month 6 of TB treatment, and will follow the time de-escalation schedule. The difference between ID93 and M72 are basically the number of antigens they are present in the candidate vaccine, while ID93 will have antigens for infection virulence, active disease, as well as latency, with an adjuvant, which is GLA-SE, which is a second generation TLR4 agonist, which is different than M72, where there are only 2 antigens for infection virulence and active TB disease, and adjuvants is an AS01. So in conclusion, treatment outcomes for all forms of TB, we know at this time, are suboptimal, and a TB vaccine potentially can reduce the risk of TB recurrence and post-TB morbidity and improve cure, as well as simplify TB treatment. However, at this time, there are no vaccines which are being used for this indication of as an adjunct to TB therapy. Therefore, the newer candidate vaccines may require some novel trial designs, and at this time, we believe that therapeutic TB vaccines may contribute to population level impact. I would like to acknowledge my colleagues here who have shared some of their slides. my colleagues who work with me for almost all of our projects, and our funders, Report India, as well as my colleagues in Pune and elsewhere. Thank you.
Thank you, Dr. Vidya. I think in the interest of time, maybe we'll move to the next speaker. I'll request, those who have questions to please, put them in the chat and request Dr. Vidya to respond to them there. So moving on to our next speaker, Dr. Asha Frederick. She is the Additional Director, Directorate of Medical and Rural Health Services, Chennai, and oversees the implementation and management of the National TB Elimination Program across the state. She's obviously playing a pivotal role in coordinating TB control activities across the state, and is very actively involved in strengthening diagnostics, treatment adherence, as well as community engagement. Over to you, Dr. Asha.
Hello and good afternoon to everyone. So I thank the organizers for this opportunity to talk on how the government program of national TB elimination is in Tamil Nadu especially is aligned to the global NTB strategies. And so obviously I'm not going to directly address the title, which is the research gaps, because as we all know, I think there are many speakers who had addressed that already. So I'll kind of stick to the topic that is given to me. So could I just ask one of my colleagues to present the slides so that I can, we are in different places. So Dr. Kishore, yeah, thank you. The NTB strategy is mainly based on 3 pillars. One is patient-centered care and approach, and prevention, having bold policies and supportive system. And also the last one, which is very important, intensified research and innovation. So as I was listening to my previous speaker, all I could think was, when are we going to get a vaccine? So as a implementer of strategy program NTP in Tamil Nadu, so what is very important is the vaccine, a new vaccine that could help us, any infections. TB is the only one which doesn't have a vaccine, which is very important, which is one last milestone that is we are all looking forward to. So having said that, so what do we have to do as to implement the proper NTB strategies? Definitely to have a robust, build a robust infrastructure, health infrastructure. So can I go to the next slide, please? In terms of infrastructure in Tamil Nadu, so I'm just going to show the context in here. So we do have one of the best infrastructure in the public sector, and the NTP in Tamil Nadu is having not MOUs, but we are implementing in all these public sector and also major private sectors. We have been implementing the NTP, which is very, very vital to NTP. Next. In fact, this is just to show you how much of the infrastructure is very important in NTP. So at the primary care, say, we have around more than 2,200 primary health centers across the state. And we've made sure that a NAT is made available in every block of the entire state. So that way, and these are distributed among the primary health centers, the government hospitals, which is the secondary care, and the medical colleges. So that now that the new strategy is to go for upfront molecular tests and to detect the drug sensitivity pattern of the patient, even at the first instance. So we have made or we have ensured that every block is having at least one NAT machine. So what do we do is we have built a very robust integrated lab network. So we have optimized the lab networking so that wherever the sputum is collected, it gets transported to the nearest NAT center. So when I place the NAT machine in strategically important place, So there is access for all these sputum to be collected and to be deposited in that hub. We get the result, proper result at a very appropriate time. So we are reducing the microscopy and we are improving towards the NAT. Next, please. And the next, this is what I was telling you, the total number of samples that are transported in integrated essential lab services is something around to the tune of 11.52 lakhs. And there are about 755 hubs and 2,427 spokes, which transports not just sputum samples, but all samples, or even blood samples and all that. So this takes a very vital role, and it's a very critical point here, because at the instance of diagnosing a patient, we also need to implement the differentiated TB care, where there are a series of 17 or 16 tests that needs to be done for the patient. So this IELS system comes in very handy, where we do draw blood and look for other comorbidities, so that an appropriate treatment can be initiated simultaneously with the initiation of TB treatment. Next, please. Yeah. So the other important infrastructure strengthening is the chest X-ray in the digital mobile vans. So we have installed digital X-rays in these mobile vans, which are used for active case finding. The recent prevalence survey in Tamil Nadu that was done 2 years back by the prestigious ICMR NIRT said that about 36% are asymptomatic, meaning to say this incipient TB, patients don't acknowledge their cough, or they just brush it aside. And it also, the prevalence survey told us that the X-rays that were taken during the survey pointed to the 36% of missed cases. They did have a lesion, but they did not report to the system. So this upfront X-rays for vulnerable groups are being done using this digital mobile X-ray vans, which is playing a very pivotal role in our case finding efforts. Next. Yeah. So, and as I said earlier, we have partnered with almost about 4,900, almost about 5,000 private facilities. And there are about half of them who notify at least one TB patient or one case every year. And this is the lab networks we have, and with the private chemists as well, wherein we, from on every month, it is, they have to report if they have any cases. And this private sector collaboration is going on very well in Tamil Nadu. Next. After NAT, as I said, if you see, there is a 341% increase in the fourth quarter of 2024. That's when we expanded the entire NAT across the entire state, so that we have increased the upfront nucleic acid amplification test or rapid molecular test. Next. This is what I was talking about, the latest prevalence survey. So we also went ahead. I think Tamil Nadu is the only state after the national prevalence survey that we wanted to understand the prevalence that is in the every district-wise prevalence, so that we can, dovetail some of our infrastructure, the interventions according to each of these districts. So that way, we had the NIRT had given us that 210 per lakh is the prevalence, and prevalence is more among adult males. It also gave us that more than 65 years old, the prevalence was very high, so that we know now where to concentrate and to include them as the vulnerable groups. Also, as you all know, of course, the BMI less than 18.5 and diabetes mellitus, alcohol consumption and smoking among patients in Tamil Nadu. So what is the prevalence was given? So next, please. Yeah. This is something that the Central TB Division, Government of India, had shared with the Government of Tamil Nadu, that it is a mathematical modeling as to how the incidents have been brought down. So, but we have a long way to go, but then it just helped us understand where we are and what interventions have to be made. And we've also engaged with some of the experts in World Bank and WHO to do modeling further for the up to the current state, and it is underway. We still don't have the exact report. Next. The TB case finding efforts as per the NTB strategy and also as COVID gave us. So the more we test, the more we can find. So we have increased our presumptive TB examination rate. And in fact, we have told some of our the medical officers in the public sector and the private sector as to go for cough of cough of any duration could be also be taken as for screening for TB, because we know who are the vulnerable groups, and there are people when they come to the hospital they report late. So by the time they could have passed 1 week of cough, they could have just brushed aside that this cough is not very important. So that way we could have more people coming forward. So that is how we increased our case finding and we improved our TB examination rate. Next, please. And the notification trend across private and public, if we look very closely, the private sector notification because of the efforts have gone up, so that we do not miss patients who report to the private sector who get notified. And with the availability of drugs for MDR TB, we also find a positive approach from the private sector to notify and to bring the patients into the registry. Next. This is something that we look as to how much of case finding efforts go into each of these primary, secondary, and tertiary care, just to give the outlook as to still there are patients who get detected more in the medical colleges. So the medical colleges have a more important role in case detection, and they continue to do so. This is just to say that more extrapulmonary patients and extrapulmonary TB are being detected at the medical colleges. Next. This is just a comparison, because we are always given a target of so many patients through estimates. So the government of India gives each of the states a target to be for case notification, TB case notification. And this is how we've been faring across the 2 years, 2023 and 2024. Next. Our success rates has increased, and also death rates have reduced. So what we do for this is, as I said, implementation of the differentiated TB care. That is very, very important to achieve the second SDG goal, as bringing down the mortality. So we also found in our verbal autopsies that are being done that many of these patients just not die because of TB, but because of the comorbidity that goes unattended. And that is where the importance of the differentiated TB care comes in. So these patients have to be simultaneously addressed. Very importantly, we found that diabetes mellitus patients are on oral hypoglycemic agents and not on insulin. So, so these are addressed then and there through the network of specialists available in the sector, in the public sector. Fortunately, we do have a medical college for every district, and specialists available. Specialists are available in these secondary and tertiary care hospitals. But then it is a very long fight to reduce the death rates in Tamil Nadu. Also, yeah, next slide, please. Drug-resistant TB, now that the new BPAL-M regimen has come in, and we have started rolling out the new BPAL-M regimen. But this is how the drug-resistant TB case finding is. Tamil Nadu, fortunately, we have the burden of drug resistance is less. Nevertheless, as I said, upfront NAT has increased and their UDST has increased, so that we don't miss patients. DRTB patients are not missed at any point. Next. This has been discussed already. Next. So, in this differentiated TB care model, what we do is we use a slightly different approach of triaging, where the staff, NTP staff, just look at the patient and try and find out where the patient is very thin, because the BMI is already available when we, and also whether the patient is able to stand with support or without support, whether he has pedal edema. So this doesn't need a doctor. So in the field, field, it is very easy when the NTP staff visit the patient at his house. And it is also said, I mean, we tell the staff to inquire with the patient's family as well, counsel the family to give more support and to bring the patient for admission into facilities, because there are many times refusals. So is it, if the tablet is available for the disease, why don't you just give me the tablet? I don't want to get admitted, is what the reply comes to the patient side. But then there is an amount of counseling that goes into the field to ask the family to support, get the patient admitted, to address the severity of illness or the severity of the comorbidity, be it TB or the comorbidity, that gets addressed. So that way, this differentiated TB care and then model is called Kasanoi Irapila Thittam in Tamil, where we have admitted so many number of patients, and we make sure that at least a minimum of 7 days of inpatient care is given, and depending on the physician's decision to discharge the patient, they can then go on for their domiciliary treatment. And we also see to it that these patients get followed up after discharge, and see to it that how many deaths are reported, there is how well the deaths are being averted in this model. Next. The Nikshay Mitra is, again, this is an additional nutritional support scheme that was introduced by the Government of India, which Tamil Nadu follows, and we've been successful in distributing almost 26,886 food baskets to patients who need it and to the families of patients who need food baskets. Next, please. Next. Yeah. So other than this, artificial intelligence solutions are being introduced in 6 districts of Tamil Nadu under the digital X-ray, wherever the vans. So that, and we are also planning to expand this AI-based X-ray screening across the entire state. So that it needs a lot of investments, but we've been requesting the government to support us in that, and I hope very soon this will happen. So these are some of the strategies and interventions that the state of Tamil Nadu is now doing under this scheme. So thank you so much. That's it from my end.
Thank you, Dr. Asha. We are back on track as far as our schedule is concerned. So if there are any questions from Dr. Asha? Dr. Asha, do you have any information on the current utilization of the CBNAT install base in Tamil Nadu?
Yeah, in the sense, just the numbers, or?
I mean, how is the utilization in terms of the capacity?
Yeah, in terms of the capacity, right now we are running one shift. So one shift is running fully, but then we could run another shift as well, because the microscopy is now like it's 60-40. 60% in NAT and 40% still goes to microscopy. So we want to increase that more, and we've asked. I mean, that's the expansion is more phased. Otherwise, we would be needing another shift set of lab technicians to run the second shift.
Thank you, Dr. Asha.
Thank you.
So there are no more questions.
If I can ask, sorry, I forgot to raise my hand. Sonali here.
Yeah.
Thank you, Dr. Asha, for that nice explanation of what's going on in the program. I just had a question about, we are actually appreciable of all the support that we get from you in research projects across various districts in Tamil Nadu. But how prepared is the program to help us in enrolling in patients for different trials? If we are trying to do some trials for drugs or vaccines, because as we hear some new regimens and shorter regimens, so it would require, some patients, maybe those will be randomized trials, some randomizing to trial arm where they would get some additional drugs. And is that okay with the program and your support?
So as a program manager, so I would like to tell all the researchers here that we welcome any new novel interventions and researches in Tamil Nadu. So to Sonali ma'am, we've had a long collaboration with your institution. So we'll be very glad to and will provide support in terms of enrollment or any multicentric trials that you would like to know to all of them. So in Tamil Nadu, we welcome such interventions.
Thank you so much, ma'am. Your help and support is helping us in a big way in conducting our studies. Excellent.
Thank you, Dr. Asha. So we'll move on to our next speaker. It's a pleasure to introduce Arnab, who's a dear friend and a former partner in crime. Arnab is the Associate Director of Global TB at the Clinton Health Access Initiative. And in this role, he focuses on enhancing TB care and control strategies, particularly within India's private sector. He has co-authored research examining the impact of providing free TB medications on patient follow-ups and treatment outcomes in India's private sector. Additionally, Arnab has contributed to modeling efforts on the potential impact of expanding services offered by the JEET program, which was a Global Fund supported project done almost 3 to 4 years ago. Over to you, Arnab.
Thanks, Ajay, and thank you, Sonali and team, for inviting me here. Let me just quickly share my screen. Can someone confirm if it's visible?
Yes.
Perfect. Okay. Thanks, everyone, and good afternoon, everyone. It's always a tough ask to follow Dr. Asha after her wonderful presentation, but let me try to do some justice to this. So, I think the topic I was given was strengthening TB research and looking from a policy and global investment perspective. How I have interpreted this, and maybe kind of the core focus of my talk would be on, I'll focus more on implementation research and, I think how that is very important and critical as we think about effective policy rollout in the country. So, as everyone knows, I think India's done remarkably well in coming up with really, coming out with various policies on critical areas to improve access to TB services and improve, obviously, the quality of TB care and outcomes. Some of these are like first of its kind in the world. So I think, especially the focus on nutrition through the Nikshay Poshan Yojana, PMTB, MBA, and other programs. So I think there's just based on our experience, I think there's obviously no dearth of good policy. I think the challenge many times happens is that the implementation of the policy, and for that to succeed, there are a lot of elements that need to fall into place. Firstly, I would say there's political will, and obviously linked to that is whether there's adequate financial allocation and finances for that policy or that initiative. The availability of commodities, be that drugs, diagnostics, if it's nutrition, food baskets, rations, which will enable kind of implementation of the policy is obviously critical. Third key pillar would be community participation. I mean, it can include the awareness, their interest in that, acceptance, and then obviously the demand for that. And finally, I would say, uh, the delivery model. How do you actually implement whatever policy on the ground? Are the HR personnel who are actually going to implement this, are they motivated? Do they really understand this? What's the enabling ecosystem for them to succeed, be it in terms of systems, IT systems, or processes, incentives, and other things? Now, my focus, I think, mostly I'll talk about delivery models and how that's kind of critical across some of these various policy initiatives that the NTP has launched over the last few years. And I mean, just to kind of summarize all of this, it's also important to have well-defined monitoring and supervision frameworks to ensure that policy is actually being monitored and tracked and reviewed on a regular basis. Let me start with you know some of the work that's happened on public-private mix or private sector engagement in India. As everyone knows, I think there is a lot of evidence on, and this is like, around 10 to 12 years back, there was a lot of evidence on how big the private sector is and how critical it was to kind of engage them effectively for both TB control and eventually elimination. Different studies had shown that, using drug sales data and other sources that anywhere between 1.2 to 5 million TB patients might be seeking care in the private sector. Now, modeling also showed that effectively engaging them can reduce TB incidence by up to 21% and reduce mortality by up to 38%. However, various studies had also shown, including standardized patients studies, that the quality of care in the private sector was poor, non-standardized, and outcomes were questionable. There's also like inherently lack of trust between private sector providers with the public sector. And generally, the TB program didn't necessarily have the HR or the capacity to effectively engage with the private sector. Some of the policy initiatives that have been taken over the last few years, there was the Gazette notification 2018 that mandated notifications, and there were kind of penal provisions for not notifying. Incentives for private providers were agreed upon and are effective from 2017, 2018. There's also guidance document which talks about partnerships and how do you implement partnerships and PPM, which was released in 2019. Obviously, having all of these guidance and kind of policy provides a good framework for implementing. But I think what has really worked from a PPM perspective in India has been like a very well thought through scale up plan. So the initial pilots around PPM started around 2014. There was the Public-Private Interface Agency Model PPI pilots that were supported by the Gates Foundation in 3 districts of Patna, Mehsana, and Mumbai. These, along with the pilots and the implementation, I think there was a very strong implementation research and research agenda on the back of those pilots that really helped answer some of the critical questions on how effective are these interventions, how much will it cost to scale up, what's the impact on quality of care, and you can see the numbers at the bottom of the screen that in Mumbai and Patna, for example, the notifications in Mumbai, the case notification rate improved from 14 to 210 within the span of just 3 to 4 years. Similarly, in Patna, it improved from 64 to 163. So there's massive improvement in notifications, while public sector notifications were mostly steady or slightly flatlined. These pilots kind of provided strong evidence that such interventions, and not just the intervention, but how do you actually implement these models through involvement of third-party agencies to actually do the engagement on behalf of the program, are successful, are cost-effective, and obviously result in an improvement in quality of care as well. They were subsequently scaled up through global fund support, through the JEET project, which was implemented across 120 odd districts between 2018 and 2021. The learnings from the PPI were kind of integrated into this PPSA model. But there were also critical differences. I think the PPI model was implemented very standalone, where drugs, diagnostics, everything was kind of funded by the donor. Here, I think here linkages were established with what was already available in the public sector. So the model kind of became more lean, more fine-tuned, and kind of more cost-effective vis-a-vis the initial pilots. Uh, Again, good thing is there was again additional research which was done, which demonstrated that this was effective. I think a lot of publications have come out uh, on how the quality of care improved in the private sector because of this work. The results are obviously were also really great. I think TB case notifications more than doubled from 2017 to 2021 at the national level, and a lot of that was contributed through the JEET project, as you can see out here. And finally, I think 2021 onwards, all the PPM work or the PPSA model has been now completely taken over by the government and by the NTP program by contracting out agencies through their own domestic budgets. As we speak, there are anywhere between 230 to 250 districts which are implementing PPSAs across all countries. And if you look at overall impact, I mean, in a period of less than 10 years, the annualized case notification rate from private sector has actually improved from like 3.1 to almost 60. While public sector notifications have kind of remained more or less consistent. So a lot of, I think what was thought as policy and what was the objective has been kind of successfully been implemented because of, a well thought through plan of piloting, testing, but also doing a lot of implementation research which can inform further scale up. I'll move on to TB preventive treatment. Again, this is also fairly new, and I'll contrast it a bit with how PPM kind of got scaled up a few years back. So, as many of you all know, that the TPT guidelines, the programmatic management of TB preventive treatment, were released in 2021, and that expanded the recommendation on TPT to household contacts and other high-risk groups. Earlier, the focus on TPT was most only on PLHIVs and under 5 children. And through this, I think, based on a lot of the global evidence around effectiveness of TPT amongst household contacts, the guidelines were revised. Additionally, it also recommended newer regimens like 3HP, which has been shown, non-inferior to isoniazid, but I think, has much better treatment completion rates because of the shorter regimen being once a week for over 3 months compared to a 6-month daily INH regimen. And also, CYTB, which is a skin test for kind of screening and identifying TB infection. So again, the guidelines were in place. The government's also now procured 3HP as well as CyTB, and that's available. And initially, to really support the scale up of TPT amongst household contacts, there was a global fund project between 2021 and 2023 that implemented this model across 208 districts in 22 states. In the remaining districts, it was the NTP which was kind of rolling it out through its existing systems and structures. 2024 onwards, the Global Fund project ended, and all of this activities mostly transitioned back to the NTP. You'll see, impressive numbers of scale up, right? I mean, in 2021, around 500,000 people were put on TPT. That tripled to approximately 1.5 million. And you'll see that most of this increase is because of household contacts of TB patients who are now being initiated on TPT. A lot of this increase was contributed through the Global Fund project. In 2023, more than 40% of the initiations were through the Global Fund project. But it wasn't all rosy, right? I mean, the guidelines for TPT recommend, if available, to rule out active TB using chest X-ray, but in the Global Fund project, only around 27% of contacts were actually screened using X-ray. While TPT completion rates were high, you can also see that the case notification rate amongst household contacts is actually quite low. It's 136. You would expect that household contacts being high risk, the case notification rate or the number of positive cases identified or diagnosed would be much higher. But unfortunately, it's lower. And if we look back, I think if we just contrast it to the PPM journey, here, unfortunately, there was no benefit of doing small scale pilots. I think the Global Fund project suddenly ramped it up, and I think while it definitely improved uptake, I think the quality of care and quality of services were there were mixed experiences. And going back to my earlier framework, I think the service delivery model of how do you deliver TPT was not really well tested or well understood. And now with the transition of the Global Fund project and everything now being done through the NTP, I think my sense is that TPT numbers are actually going to drop because for existing program staff, I think it's a bit it's an additional work. It's a lot of work to now manage TPT as well. So if we think about what would be key research priorities, or what would areas be to really think about TPT scale up, I think we really need to think about sustainable models to improve coverage, and can actually be categorized based on whether it's PLHIVs, under 5 children, adolescents, and adult household contacts. Uh, as I said, the guidelines recommend both TB infection screening as well as active TB screening, but that may not be possible every year. So how do you prioritize? What are the appropriate settings where you can implement these screening strategies, testing strategies is again important to understand so that it can be implemented effectively. How do you improve access to TPT services? I think one of the major barriers for TPT uptake, outside project settings is that many times household members are asked to visit the facility for screening and to be initiated on TPT. But if you think about it, there's very little understanding of why should community members or household members initiate on TPT. The risk, the risk perception is fairly low, and hence, many times people don't visit the facility for screening. And can we think about community-based delivery models? I think, especially for under fives, there is as per WHO guidelines, you can just rule out TB through a symptom screen and directly initiate them on TPT. So I think, are those models more effective? Would that improve coverage? Are, I think, again, important questions to understand. I spoke about the understanding and acceptability of TPT in the community level. I think that's very low. I think that generally TB risk perception is low. I think TPT is even further away. And then also, I think some of the newer regimens like 3HP have higher ADR vis-a-vis, let's say, 6H. But then what are more effective strategies to manage that, and how do you improve that? And again, I think what works better in a real-world pragmatic implementation setting, I think, would be critical questions that can be prioritized for research. Just moving ahead, I'll talk a bit about nutrition support. Again, everyone's aware that recent studies like the Rations trial, as well as some of the work that the Report India Consortium has done, has showed that how nutrition supplementation is very important. It not only improves treatment outcomes, but can also act as like a vaccine in terms of reducing the incidence of TB amongst household contacts. Now, the government's recently also, let's say, through the Nikshay Poshan Yojana, doubled, the doubled the benefit that's provided to index TB patients from 500 to 1,000 rupees. Also announced that EDNS will be provided to severely and very severely undernourished patients. And then the PMTB MBA programs also been expanded so that even household contacts are eligible to receive food baskets and not just TB patients, which is all wonderful. I think this is all important, and I think there's strong evidence to suggest that strong implementation of this will have a material change or impact on TB incidence in the country. But if you just look at the Nikshay Poshan Yojana, I think it's been implemented from 2018, so it's been 6 to 7 years. This is an evaluation which was done in 2023 based on first 5 years of implementation. So if you look at it, I think 76% of patients received at least one installment of the payment. This is like, a couple of years back. The median time to receive the payment, while that had improved from 200 days, it took 3 months to receive the payment. Uh, and only like two-thirds of patients received the first installment within 6 months of diagnosis. And which is what is, I think, worrying is that, you know, the proportion of patients with unfavorable outcomes who receive their, NPY payment uh, after outcome declaration was like two-thirds of them. And I think this goes back to the question of quality, right? I mean, it's a great policy initiative, but I think because of processes, because of maybe inefficient processes, and I think perception of greater workload, the implementation of it, a lot of these benefits are reaching people much late, and that uh, can be argued that maybe if some of the patients who had poor outcomes got this earlier, probably the outcome could have been much different, could have been improved. So the question is again, how do you improve this? How do you improve the processes of, let's say, NPY payment as an example? I think kind of a complementary qualitative study which was done highlighted some of the needs and challenges, right? I think there were suggestions around simplifying the Nikshay portal so that this process can be simplified, that there's need for improved or more technical support to staff to understand this. A lot of the frontline workers, TBHVs, STS, others felt that this was a lot of workload and was actually taking away time from patient engagement. And amongst TB patients and their households, they didn't know how to utilize this money. I mean, it was meant for nutrition, but then perhaps counseling them on how effectively to use this 500 rupees might have been useful for them to spend that more efficiently. So coming back to again, I think what can be done and how can research or implementation research kind of help. Uh, you know, we are doing cash transfers. There's food baskets through PMTB MBA. Can we consider increasing the rations and what's more effective? What works better, and what is practically the best way to kind of deliver this? I think research around that would be critical. Uh, if we talk about rations, what are effective delivery models to do this? I mean, uh, is it like, I think some thoughts are like doubling the rations that people are already eligible through, because they're falling under the poverty line. Are there other models of doing it? What's the acceptability of EDNS while it's been kind of announced? I think how many people would accept it? What are other alternatives if it's there? How do you reduce the delays in NPY payment? Can we, think of models of fast tracking bank seeding and verification process, which usually take most of the time and account for a lot of the delays? And then, uh, is there a need to think of prioritizing NPY payments or ration delivery to high risk individuals? Like, if you're severely undernourished or undernourished, should that cohort of patient be prioritized so that at least they receive at the earliest because they are at maximum risk of poorer outcomes? Uh, Finally, I'll talk about asymptomatic TB and ACF. And again, I think there is increasing evidence on the need for mass screening approach as an effective way to kind of actually reduce TB incidence. The Act 3 trial, which was done in Vietnam, kind of showed that how mass screening and repeated mass screening over a period of time can reduce TB incidence by 60 to 70%. There's also, I think, evidence around asymptomatic TB. That's like, someone who has TB disease, uh, is infectious but does not display symptoms. I think recent evidence suggests that prevalence studies have shown that between 40 to 60% of TB cases are actually asymptomatic. But also recent evidence has shown that these patients are actually transmitting, and 68% of asymptomatic TB transmission takes place. It's not like coughing is necessarily required. There's also modeling studies which show that 18% death amongst asymptomatic TB patients. So again, I think the point is this is critical, and active case finding is probably the only way to make sure that you're screening and identifying these cases early enough. Uh, Now, from a policy perspective, I think the NTP recognizes this. The recently concluded 100-day campaign was focused on asymptomatic cases. The government's investing a lot in procurement of X-ray, ultra-portable X-ray, and CAD solutions. I think more than 1,000 are going to be procured at the national level, but also some states are going ahead and doing their own procurements, which is all great. There are initiatives like TB Champions, TB Book Panchayat, all of which is meant to kind of raise awareness and drive kind of community participation towards TB screening. However, again, I think where the rubber hits the road, I think there are significant challenges. I think, and a review of ACF done in 2021 showed that I think the quality of ACF implementation is very poor. I think amongst various things, I think in terms of eligible population, I mean, less than 9% of the eligible population gets screened, got screened. 1% of them get tested vis-a-vis how many should actually get tested. And out of that, how many actually get diagnosed is even lower. So the number needed to screen, comes out to around 2,824. Based on program guidelines, that should be around 1,500. And, I think that kind of reflects some of the challenges in ACF implementation because, in many cases, it's existing staff who are doing it without necessarily having the adequate tools. And that kind of leads to, poorer kind of poor quality implementation and hence poor outcomes. Uh, you know, when this evaluation was done, I think none of the states or districts met, the NTP guidelines on what population need to be screened and what should be the NNS. So I think this goes to show that I think there needs to be, I think while the policy is there, while there's good understanding that this is valuable, the question of how do you deliver this, how do you get this done, is something that really needs to be thought through as the kind of program thinks about TB elimination going forward. But again, I think coming back to what's the model, what's a sustainable model of mass screening? I think there's greater evidence that using X-ray is, I think, the right tool. But then, do you do it using existing program staff? Do you outsource it like PPI, private sector engagement that was done? What are the other models that can be used? Do you decentralize this really up to the AAM level? How do you actually do this on a sustainable way? And how do you improve, let's say, community participation in the health-seeking behavior? I think, based on some of the experience of our work, I think we've seen that branding or kind of saying these are TB camps, can create stigma. I think the simple communication, like positioning something as a health camp, can actually improve participation because then people see value in participating in the health
I don't know. Is it just me or did we lost?
Yeah, actually, I was just thinking it's me alone, not able to hear.
We lost Arnav.
Yeah.
Sorry, Arnav. I don't know if you're able to hear us, but we lost audio at your end.
Dr. Sarin, if you have his number, can you just message him because I don't have his number. You can write to.
Hi, I work with Arnab and I have messaged him just to check.
Okay, good.
Let me just call him as well and come.
Sorry about that. I hope I'm audible.
Yes.
Yeah.
Yeah, we are almost on time, Arnav. So
Yeah.
another
I'm just
2 minutes.
wrapping up. Yeah, sure. Yeah, I was just kind of wrapping up anyway. So I think I was just saying that, I think in terms of research priorities and strategies, I was just talking about what would make most sense. I think from a diagnostic algorithm perspective, focusing instead of the tools with the highest diagnostic performance. I think looking at what's the diagnostic yield of your algorithm will be critical. And again, I think research on those and a kind of implementation research studies which help you evaluate different algorithms would again be critical. But yeah, let me pause here. I think I'm also at time, so hand it over to you, Sanjay.
Thanks, Arnav. I think this is for the most interesting conversation. Obviously, I think I've been sort of associated with a lot of this work. So great to see you putting this into perspective. We have time for a couple of questions from Arnav. Yeah, Dr. Sonali.
Thank you for that very nice talk, Dr. Arnab. My question is about the TPT. There are studies from India, but not which cover all parts of India about the infection levels in the household contacts. I mean, it varies because we see in our site in Pondicherry, we find very few household contacts who have infection, and the incidence of TB in them is very, very low. As compared to 2 to 8% in rest of the country or world, we have less than 0.5% incident TB among our household contacts. So when we talk about TPT and the full focus is on the household contacts and forgetting the other social contacts in this context, and my question is about when we do it, implement it in the program, what is your experience? Are the household contacts being screened appropriately or adequately for TB disease before being given TPT? Or if it is not being done, or the feasibility of screening with chest X-ray and going for a microbiological test on the induced sputum if they're not able to cuff up sputum. And now we know the presence of subclinical TB is so high. So if we are treating them who have probably subclinical TB or even active TB, if not tested properly, and giving that one drug TPT, I mean, I feel there should be some modeling to see the effectiveness where the infection levels vary, and the programmatic implementation of TPT, whether it is going to be actually useful or counterproductive in, I mean, our fear is that it may later on increase the resistance to drugs if we are treating patients with a TPT. So
Yeah.
sorry for a long question.
No, I think that's a great question, and that's very relevant, right? And so I think there are a few points, right? One is why are we, I mean, whatever, I think in the Global Fund project, we found like 136 cases, whatever, 3,800 cases out of around 2.8 million people who are screened. Part of the reason is that, the guidelines do not mandate a chest X-ray to rule out active TB. And hence, wherever X-ray wasn't available, there was only a symptom screening done and people were initiated on TPT. But there was significant variation. In some geographies, we were able to kind of successfully get an X-ray done for household contacts. We found that, if I 2,800 cases of the 3,800 were actually identified because of wherever we did an X-ray. And if you just to kind of analyze case notification rate, we saw like 800 per 100,000 population amongst the cohort that actually got an X-ray. So to your point, I mean, if the algorithm is followed and we do the X-ray, then I think you're more likely to find a lot of these asymptomatic cases and who would have probably been missed if it was just a symptom screening. And that also has a cascading impact. Then probably they'll have poorer outcomes. It can lead to greater drug resistance and so on and so forth. So the question then becomes, how do you ensure or enable access to X-ray in a programmatic setting such a large scale? I think where we were successful, we were able to kind of partner with private labs and link patients to the private sector laboratories through vouchers and other mechanisms to kind of get themselves X-rayed. But because within the public sector, there may not be that much capacity to do all of these X-rays. The other option you can think about it is now with all these handheld X-ray being procured, is there a way to link these household contacts to those handheld X-ray machines and make sure they're screened before TPT initiation? Okay, I mean, I think it's important to figure out what works best and given all the constraints that exist in the system.
Thank you.
Thanks, Arnab. If there are no more questions from Arnab, perhaps we can get to the last session. May I request Dr. Selvaraj to please give his concluding remarks?
Thank you, Dr. Sanjay. So I think overall we had a wide spectrum of talk on identifying what are the possible research priorities that could be taken the next few years to see that we strengthen our TB elimination goal. So what I would like to suggest is like, so in the major challenge or what we want to do is to see a steeper decline in incidence and mortality, which we are finding it difficult to do. So that is the major challenge which we need to address. So if that is the goal, that we need to reduce the incidence and mortality to a greater level, then our research and intervention should be focused on that direction. So if we have to do that, the priority should be more on TB infection. So we need to have more understanding of the TB infection, how it progresses, and what are the predictors of those people among those infected who are going to progress to disease. And then also like, because now even the NTB strategy does not have an indicator for TB infection. So unless otherwise we control the infection, we would not be able to make a dent in the TB disease and mortality. So only if we prevent the pool of infection, we can further reduce the disease and mortality. So in that context, like the strategy also is detect, treat, prevent, and build. So we have now more activities happening on detect and treat, but it should also be complemented and supplemented by the prevent. So unless otherwise we do detect, treat, prevent at the same time, even if we detect, so before detection there is already transmission happening. So unless otherwise we prevent that infection pool, we would always be have to do more detection and treatment in the subsequent time point. So that is where our research in both basic science and also in applied research, we should have more strengthened research in the area of TB infection. And also in terms of the other tools that we discussed in terms of molecular diagnostics and targeted next generation sequencing. So we need to see how we scale that up with indigenous products to the last mile, so that we are able to have the diagnosis using molecular test with the universal drug susceptibility, as Dr. Camelia mentioned. So that would strengthen the early diagnosis and the treatment with appropriate regimen, which will have better treatment outcomes and reduced recurrence, which will also further reduce transmission. And also speaking in terms of all this intervention, so we need to see how we apply these interventions, because in the background the epidemiology is changing. So previously we did not see this many number of diabetes. So now diabetes prevalence is increasing, anemia, smoking, alcohol. So all these behaviors are also changing, and then we have to see how we address these challenges. And on the other side, in the positive note, we also have emerging technologies, but we need to see how these technologies could be scaled up with better cost-effective strategy to see that they reach the required population. So to see that, so there needs to be a lots of collaboration between the basic science and the applied science in terms of the clinical and public health people. So that would focus the research that is being carried out at the basic level to see that it is more relevant and it is more helpful in generating evidence, which would generate evidence for interventions which would make the most dent in the incidence and mortality curves. So for that, more collaboration in basic science and applied researchers are required. And so that is what should be the focus when we do the research in the upcoming time period. So that is from my side. Thank you.
Thank you, Dr. Sriram. So I think I couldn't agree more with you in terms of whatever you said. needs to be done in order to address this scourge of tuberculosis. My thanks to Dr. Sonali and the organizers for making me a part of this very interesting day. I think it was a very well crafted agenda which touched upon all the aspects of tuberculosis, from prevention to diagnostics to obviously vaccines, therapeutics, as well as community engagement. And then we had a great example of how the program is being implemented through the conversation with Dr. Asha. As we saw, the TB diagnostic pipeline is quite encouraging. There are several new technologies at various stages of development and trialing, and this includes the point of care technologies, the near point of care technologies. There is also a lot of interesting work which is happening in validating non-sputum based samples for TB tests, as we know that sputum is not necessarily the easiest sample to be drawn, specifically when we're talking about pediatric TB. So all of this augurs very well for the future. Dr. Camilla, she obviously spoke about the importance of sequencing and compared the targeted NGS with the whole genome sequencing. There was a significant amount of gene sequencing infrastructure that was built into the country during the course of the pandemic, and there is a great opportunity for us to leverage that infrastructure. Specifically when we are seeing that the phenotypic methods are not best suited to look at the resistance for new drugs like bidaclin and laminate. Cost obviously is a huge challenge, but this is something that can be overcome by potentially exploring volume-based pricing with the manufacturers. Great and interesting conversation on the role of AI/ML in TB genomics by Dr. Mohanty and also by Dr. Shibu on the role of AI/ML in imaging for both chest X-rays as well as for point-of-care ultrasounds. And then two great talks by Dr. Nishit and Dr. Thirumalai on emerging research in TB therapeutics. Obviously it is, while there are newer drugs that are becoming available, the world is shifting from injectable to oral drugs. I think it is important for us to continue this very important fundamental research and look for opportunities where this research can potentially be translated into commercial solutions for TB therapy. Dr. Selvaraj, he raised the issue of comorbidities. I think it is very critical to focus on that part, because diabetes, which we know is a predisposing factor for tuberculosis, is something that India is unfortunately home to as the #1 country for both TB and diabetes. And then there are other environmental factors like air pollution and also which are further modeling this whole scenario and are increasing the propensity of people to move from latent to active TB. There's also some work which is now global therapeutic vaccine scenario. And then last but not the least, Arnab spoke about, bringing all of the gist together over the last almost 10 years of, several landmark projects like the JEET project, and then the nutritional support projects, as well as the TPD scale up, which was implemented through Global Fund support. To sum up, I think it's critical to maintain this momentum in research and implementation across diagnostics, therapeutics, and vaccines. Prevention, which obviously seems challenging now in the wake of this, withdrawal of the US funding, which had been supporting a lot of this work globally. Hopefully, the impact of this withdrawal would not be as pronounced on India's efforts on TB control, as the government of India has been increasingly transitioning a lot of its TB control efforts to domestic budgets and to reduce its dependence on overseas developmental assistance. So with that, I would once again like to thank all the speakers and the organizers for a wonderful agenda and for a day well spent.
Thank you so much, Dr. Sareen and Dr. Selvaraj, for chairing this wonderful webinar. Thanks to all the speakers, excellent talks, quite learning. As part of the Report India Consortium, which was funded by DBT and NIH, it is being funded by DBT and NIH and started in 2013. We started a report consortium and building cohorts of TB patients and the household contacts, large cohorts across 9 sites in India now. We are in the second phase of report, but for a very long time, as everybody agrees, no, we were working in silos. We were not aware of many researchers working on in the TB field in India, and many were not aware of the existence of Report Consortium. So we wanted to involve more with our fellow researchers working in this space in various domains. But while I mean, we were in this webinar trying to bring all researchers from various fields working in TB. But after hearing Dr. Ramya's talk, I realized we have missed out on the, one major stakeholder of TB research, that is the patients and the community. Probably when we have an in-person meeting, we should bring them in as well. So I think it is the best time to do research on TB in India. As Dr. Sarin was telling, a lot of Indian government funding is now focused on TB. So it's a good time to do research, but I think this, what, as you rightly said, Dr. Sarin, the momentum has been built up and we should carry it forward. And so we look forward to working more together. And my thoughts were just one program. I may not be knowing there might be other large-scale programs, but Government of India funded one major program is the Report India Consortium now. Is this enough, or should ICMR also start large program? Because programs can bring in multiple researchers, multidisciplinary research, and fund what is difficult to fund, like Dr. Nishit was telling, drug discovery and all. So this requires time and sustained funding. Smaller projects would not be feasible for this. So long-term programs would be, I think, the solution. Probably we will come out with a white paper or some of a research agenda and put forth to ICMR. Just my thoughts. But I think that's the need of the country now. Any other last passing remarks from Sen? Anything?
Thank you so much. So anything anybody else want to let us know before we close the session?
One, can I? Okay, this is Dr. Chitra from BMMRC, Hyderabad.
Hello, ma'am.
Hi, ma'am. Hi, Sonali, ma'am. Just one thought process. See, urban slums, as we know, contribute to around 30% of transmission. So, on the root level or the source level, if we can make a change in their lifestyles by providing better ventilated homes, can you not bring down the transmission?
Definitely, ma'am. But that requires overall socioeconomic development, which is a little beyond our scope as of now. I mean, this has, I think, the overall socioeconomic development is what has led to almost elimination of this disease in the Western developed world. So they did not have drugs, they did not have vaccines when they were able to control tuberculosis. It was only through better nutrition, better homes, and better lifestyle. So that would be the ultimate thing to do, ma'am. But till then we have to take care of this problem and just not let it kill still millions.
Thank you, ma'am.
We also request the participants to fill out a feedback form because we are doing this for the first time. We would like to hear from the attendees. So it is, I think, pinned in the chat box. So after you're offline, please take a moment to fill it for us. And can I also request everyone to turn on the video for a moment?
It was good to have at least almost 60 participants till the end of the day. It was a long day, a lot of talks. So thanks to all of those who persisted.
Thank you very much, Dr. Sonali. It was indeed really nice and very educative, and I hope that we will keep on having such kind of interaction in future also.
Yes. Yeah, I hope to. I should thank the Director Jipmer also for letting us conduct this webinar and for the technological support. Thanks to all the members of Report India and all the speakers again.
Thank
all
you.
the participants. Thanks, Dr. Sarin.